I think they're saying I have to like restart my computer. Okay,
All
so
right.
let me
Will you
do
try
that.
that
Yeah, yeah, let
first?
me do that. So.
Nyambura?
Yes.
Hello, Nyambura.
Yeah.
So do we have the YouTube stream, live stream?
Oh, okay. I have to have your I have to log on to the Gmail account that you used to for that channel. Can you send me that information?
Yes. I thought John had set it up yesterday because he tried to see whether it is working. I'm
Your what?
Because, like, I mean, frankly, at least for me, just going and saying hi, I'm medical student, I'm very want to be like inside of it doesn't work that way. You need to find the value you are bringing to the discussion or to the argument.
Guys, so I've been attending the World Health Assembly this week, and the youth, there's IFMSA hosts a youth okay, this time it was pre and post. Normally it's pre World Health Assembly. So we have the last two sessions today and tomorrow. So I'm kind of multitasking, but this is also a good opportunity to tell you guys about it and to apply to be delegates. So normally it happens in I think some of you will actually get to go to Geneva for the World Health Assembly. Oop, you're muted. Guys, this is quite strange. Please unmute yourselves because I'm unmuting you.
Can you hear us?
Yeah.
Clearly.
Yeah, I can hear you. Okay. What time does Dr. Martin join?
I think it would be good if she would join
now.
Who was has Yas left? Oh, I think it's Yas, but I don't know.
Yeah, he said he's restarting his computer.
Yeah, it would have been better if she joined like even now.
Yeah,
no,
go live before she did.
Is how to follow up. So in best case scenario, you're gonna have with that.
Okay.
Oh, hi, As.
Yeah.
We see you. Hi.
Hi.
Yeah, yes. Could you tell Doc to come in soonest?
Totally forgot about it. Let me call her. Hi, Dr. Maritim, how are you? Okay, Sarah, thank you. Okay, thank you. Okay. She's just logging in right now.
Yes. At what point should I start the introduction? Like we wait for how many people to join?
So basically you'll, yeah, so what will happen, we'll allow 5 minutes for all the attendees to join in. Like
Yeah.
that's after joins in, then 5 minutes for all the attendees
Yeah.
to join. Then on the
Okay.
chat, one of us will just tell you go ahead, and then you unmute yourself, and then
Okay.
you do the introduction. Yeah.
Can I just mention my introduction just so that you guys can hear it? Because I've never done this before. Is that okay?
Go ahead.
I'm sure it'll be good.
Yeah.
I'm sure it'll go well.
Never done this before, guys. Okay, so let me just go
There's
through
always
it real
a first
quick.
time of there's always a first time for everything.
Okay.
I can set the Kahoot by the time.
Okay, so hello everyone. Nice to meet you on this lovely afternoon. My name is Ruby Oswere, and I'm a level 3 MBCHD student at the University of Nairobi. So today's webinar is titled Comorbidity and its Impact on COVID-19 Patients. Comorbidity refers to the presence of one or more additional conditions co-occurring with a primary condition. Research has shown that susceptibility to COVID-19 is related to having an ongoing illness. So the question of the afternoon is, what is the relationship in various conditions and COVID-19? And how do these comorbidities influence the disease prognosis? Take us through this exciting topic is none other than Dr. Marybeth Maritim. She's an infectious disease physician and a member of the Infectious Disease Society of Kenya. In this season of the coronavirus pandemic, she is proudly part of the National Task Force for COVID-19, and in a bid to share her brilliance with the younger generation, she is also a spectacular lecturer at the Department of Clinical Medicine and Therapeutics at the University of Nairobi. You might be able to recognize her from the amazing educational video that she recorded on behalf of IDSK, whereby she educated the masses on the proper way to wear and remove a surgical mask. So just a few housekeeping rules for this session. If you have any question, be sure to submit it in the Q&A chat box. Mention your name, your school, and your country of origin, followed by the question. And if you want to ask a question using your audio during the Q&A session, then you can raise your hand and the moderator will give you an opportunity to do so. Last but not least, I'd like to wish an Eid Mubarak to all our Muslim brothers and sisters. Dr. Maritim, thank you so much for being here. You can now begin your presentation. The floor is yours.
Wow, that's perfect.
That was
It's
amazing.
good.
Thank you.
Oh, thank you guys.
It was good.
Okay, so at least I'm feeling better now. Fine.
I told you, you are good. I've set the Menti and everything. Okay. So do we have Dr. Mai?
Hi, Nicholas. Is Nicholas here?
Yeah.
Where is he?
Oh, he's not there.
Oh,
He's left.
okay.
I think.
Has Doc
Yeah.
joined?
Not yet. Nyambura, do you think we should let in participants?
I think we should wait for her. But is she here yet?
She told me she's just joining in, so
Yeah, I think it would be good for us to
yeah.
have her join first.
Yeah.
I hope she joins in the next 2 minutes.
Yeah, I think give it 2 minutes because then participants will just,
Yeah.
opt the easy way out. Yeah.
Okay.
were already said by my colleagues, so my space is really little at the moment. But as Minauka,
Okay, now screen. Okay, I can. Okay, it's done.
You're going to do the Kahoot.
The Kahoot, yeah, and there's a Menti at the end for feedback.
Yeah, and Ruby can't have her. She's muted. I think Ruby is muted. She can't come back on.
Okay. Wait. Let me tell Ruby to, let me put it on the chat. Ruby, let's unmute. She can't.
Maybe Nyambura should unmute her. Where is Doc? Because people are trying to get in.
I can't call her again because she told me she's getting in.
Oh, it's
so
okay. It's okay.
She'll tell me the same thing.
I'm unmuted now. Okay.
Okay.
So the trick is we don't mute ourselves.
Yeah, I think so.
Yeah. Nyambura, I think we can allow participants as we wait for Doc.
And then what do we put in the background?
Let me try. Do I have an image? Does anyone have an image? Like who is using their phone? Or I don't have a picture on my laptop. But let me try. It's taking time. Does anyone have a picture?
A picture of what?
Of the poster, like available on their screen that they can share. I'm trying here.
I think I can try because I have my WhatsApp opened. Just a minute, let me try.
Okay, it's okay. I think I've managed. It's fine.
Okay.
Yeah, let me try and share. Oh, okay, wait. Can you guys see? Okay.
Yeah.
Yeah, it's good. It's good.
So now we just Nyambura. Hello, Nyambura.
Okay, sawa. Sawa. Hello. Hi. Oh, sawa. Thanks, John.
So can they come in?
Yeah, I think they should just come in as we wait for them to
No, I
come.
think it will be fine.
Yeah, Doc joins.
Okay, sawa. Let me take the host. Okay, sawa. Thank you. Hi. So we can go live.
Yeah, I think let's just go live. Hopefully, Doc will join in.
Okay.
Wait, let's pick through the chat box.
Are you able to mute and unmute yourselves?
Yes.
Okay. So I think we should all mute ourselves, everyone except the person speaking. So what was, you said what team? Team, you're muted.
Sorry, if we want anything, let's just talk through the chat box.
All right, okay. So Doc is gonna join us later.
improved. Marian said, one very important thing about this that we had to pay for our own accommodation, our transportation, our flights, etc. But it was all worth it because eventually we joined the delegations and we had access. I think we have some connection problems here, right?
Yes.
Yes. So if Firas comes back, he could continue. But for now, I would say that let's move to the question and answer session. And those who have questions.
We can start.
Hello, everyone. Nice to meet you on this lovely afternoon. My name is Ruby Oswere, and I'm a level 3 MBCHD student at the University of Nairobi. So today's webinar is titled Comorbidity and its Impact on COVID-19 Patients. Comorbidity refers to the presence of one or more additional conditions co-occurring with the primary condition. Research has shown that susceptibility to COVID-19 is related to having an ongoing illness. So what is the relationship between various comorbidities and COVID-19? And most importantly, how do these comorbidities influence the disease prognosis? To help us delve deeper into this topic, we have none other than Dr. Mary Beth Maritim. She's an infectious disease physician and a member of the Infectious Disease Society of Kenya. In this season, coronavirus pandemic, she is proudly part of the National Task Force for COVID-19, and in a bid to share her brilliance with the younger generation, she is also a spectacular lecturer at the Department of Clinical Medicine and Therapeutics at the University of Nairobi. Some of you might be able to recognize her from her amazing educational video that she recorded on behalf of the IDSK, whereby she educated the masses on the proper way to wear and remove a surgical mask. So here are a few housekeeping rules for today's session. If you have any questions, submit them in the Q&A chat box. Make sure you mention your name, your school, which country you're from, followed by the question itself. And if you want to ask a question using your audio during the Q&A session, then you can raise your hand and the moderator will give you the opportunity to do so. Last but not least, I'd like to wish an Eid Mubarak to all our Muslim brothers and sisters. Dr. Maritim, thank you so much for being here. You can now begin your presentation. The floor is yours.
Thank you. Let me share my screen. So good afternoon, everybody. Thank you for this opportunity to make this presentation. Be able to ask or answer your questions. Over the COVID-19. So I'll make the presentation and I'll share the insights that we have had managing our outbreak here in Kenya. I made a presentation, and when I was making the presentation of comorbidity, but it's difficult to focus on the comorbidities. This can be, but we are trying to collect the data to see really the impact of comorbidities in our patients. As many of you might have known, a lot of our patients that our active surveillance is working to identify patients early. We haven't yet had a generalized outbreak like the USA, where you said most of our patients are relatively young, they're relatively healthy, and many of them, you might have seen some YouTube videos, many of them actually want to be discharged. So the impact of the comorbidities in our setting and in many other African countries, we really haven't seen it yet, but maybe it's because our outbreak is fairly early. And also it could be because of the lockdown strategies that have been instituted by the government of Kenya that have kept the patients with comorbidities away from the contact with people who would otherwise transmit the disease. So let's start the presentation. I will focus on the comorbidities towards the end of the presentation, but I just wanted us to look at the outbreak in general and the comorbidities thereafter, because when you look at it, my thought that you will give a treatment for people with comorbidities, because the management is by and large this. The background to this outbreak, we have to understand about the coronaviruses, and some of you might already know this or might have been covered in a previous lecture, but it always helps to put it into perspective. It says my internet is unstable. Can you hear me?
Yes, we can hear you, but it's pretty unstable. It's disconnecting at some words.
Oh, let me look for stable internet. Let me just relocate to a part of the house where I can have stable internet. Just give me like 2 minutes.
Okay, no problem.
Okay.
So as Dr. Maritim finds a place where her internet is stronger, please feel free to ask any questions during the webinar session, and we will have them answered. And if you want to ask them live, then also please go ahead and raise your hand, and you'll have an opportunity to show us how lovely you look and your amazing question as well. So please feel free to ask any questions. Thank you. Also, as you state the questions, please state the university you come from and your name, of course, and followed by your question. Thank you.
So I'm back. I hope this is more stable. You give me a cue whether it falls off, like, or I start slowing down or being unstable again.
And then, Dr. Maritim, is it possible to put your presentation on full screen?
Yeah, it's possible. Thank you. You can see it now?
Yes, we can see it. Thank you. Yeah.
So these coronaviruses, there are about 7 now. This is the 7th. So they are a large family of viruses that cause respiratory illness. And these viruses are not originally from humans. They come from other animals and then they cross over to humans. And then now they're called human coronaviruses. So they're named because they look like a crown. So they're called, the corona is from the crown, like spikes on the surfaces. There are 4 subgroupings. We have the alpha, the beta, the gamma, and the delta. They are large viruses and they are enveloped and they're RNA. And they frequently recombine and have been recombining. The first was isolated in 1960. And the animal sources include the birds, the avian species. Then we also have the bats, and then now they cross over to humans, so they become human coronaviruses. So these are the 7 coronaviruses that currently infect humans. The first 4 cause a mild respiratory illness and therefore not very significant. The last 3 that have emerged in the last from 2002 to 2019, like in the last 2 decades, are highly pathogenic, and I will talk about the outbreaks thereafter. So when you look at the first 4, the human coronaviruses, 2 of them are alpha coronaviruses, 2 of them are beta, and basically they just cause a mild illness. And it's thought that maybe infection with some of these coronaviruses may actually overlap and give protection to the current coronaviruses and the current COVID-19 or SARS-CoV-2. And this is thought that maybe people in Africa may have more of these infections and therefore maybe would have a better outcome because of cross-reactivity, but this is still not yet conclusively confirmed. When you look at SARS-CoV and MERS-CoV, they are beta coronaviruses, and even SARS-CoV-2 is also a beta coronavirus. And SARS-CoV emerged in 2019 in Wuhan city with the initial exposure associated with the wet market in Wuhan. And there've been exportation, and now it's a generalized outbreak in all the continents of the world. For the human coronaviruses, the mild ones, they actually are found worldwide, mainly appearing in winter and spring in the temperate countries, but in Africa, they are thought to be there throughout the year. The exposure occurs in childhood, and its transmission is likely to be droplet, direct, and contact transmission, which again have been confirmed for the current outbreak, that you can get infected through droplet, direct, and indirect contact. The symptoms for the mild coronavirus is, again, it's just a mild to moderate upper respiratory tract illness with the same symptoms that currently are found in COVID-19. So an early prodrome of upper respiratory tract infection, the runny nose, the headache, the cough, sore throat, fever, and a general feeling of unwell. But rarely do you get lower respiratory tract involvement. So the other 2 coronaviruses that really caused outbreaks and was feared to cause pandemics emerged first in 2002, 2003. That's the SARS-CoV. That was actually, the name was derived from severe acute respiratory syndrome. And it was first recognized in China again, in Guangzhou province, and that was in November 2002. And thereafter, there was a global outbreak where there were 8,098 cases with 774 deaths. But that outbreak ended before it became a pandemic. So the cases transmitted and died. It had a higher case fatality, and the outbreak ended in 2004. It was spread by close person-to-person contact with symptoms more or less similar to what we see even in COVID-19. Patients presented with fever, chills, body aches, and progressed on to pneumonia. And there were lots of transmission of the cases even within hospital. For MERS-CoV, this is also a regional disease found mainly in the Arabian Peninsula, and it stands for Middle Eastern Respiratory Syndrome coronavirus, so MERS and then CoV. It's a viral respiratory illness, again reported in 2012 in Saudi Arabia. And there were human illnesses in several countries around the Arabian Peninsula. So it was a regional disease. It was not so much of a global spread. And as of October 2019, we have total cumulative cases of more than 2,400 lab confirmed cases and 850 deaths. But what is noted about MERS-CoV, it's actually a sporadic illness and is thought to be endemic in that region without significant spread. So we can't quite say the outbreak has ended because there are outbreaks from time to time within that region. And you might find a case that goes into hospital and then you get nosocomial spread within the hospital. So a lot of the things now we've learned about COVID and SARS-CoV-2 are actually things that were sort of gained or derived from understanding these 2 viruses. because they were new and they emerged, and then we can even learn from, in terms of the infectiousness. Most of the current therapeutics that are being tried for COVID-19 are actually things that were tried for these two pathogenic, highly pathogenic coronaviruses, and thereafter, when the outbreaks ended, those clinical trials then have been carried forward to the current outbreak, some with success, some without success. Of important to note is when SARS-CoV emerged in 2002, I was finishing med school. So at that time, and actually in 2002, I'd finished med school, and 2003, I was joining the postgraduate program. So at that time, when you're reading things just like the way you are, many of you are medical students from all over the country, this is one of the topics you have to read for your exam, because always when lecturers are setting exams, they want to set on things that are topical. So around that time when you had outbreaks occurring when you are medical students, you must know much more, because that will probably be one of those wildcard questions in your exams, because people want you to be topical. So for those of you who are in your final year classes, definitely read around coronavirus, because a question or two would be coming out, just like for us, even when we were in undergraduate, we anticipated, and sometimes we were happily surprised that whatever we read came. For SARS-CoV-2, first identified in Wuhan in 2019, initially linked to the seafood market in Wuhan, and that market was actually closed on the new year for environmental sanitation and disinfection. And at that time, there was not so much information that was coming from China, but the WHO actually went out of its way to get more information, and all this information subsequently was published. And there was actually a team that was sent to China to go and investigate the outbreak, because a lot of information was not coming out, and they did a lot of investigation. They were able to characterize, they were able to come out with the modes of transmission. And thereafter, all this has since been published. And initially, there was a lot of denial about the modes of transmission for the outbreak, with the denial of human-to-human transmission, which actually caused a lot of the healthcare workers and a lot of families to have transmission within the household, because it wasn't categorically clarified that there was a lot of human-to-human and close contact transmission. So the genetic sequence again was shared with the world in January, and this set the way for development of diagnostic tests. The cases in the region, in Thailand, Japan, Republic of Korea, were actually cases that were initially linked to travelers who had traveled to Wuhan city. And thereafter, there has been a lot of exportation of cases, and we know how the outbreak has evolved. There have been large number of cases currently reported, with the US currently leading in the statistics, with more than 1.5 million, close to 2 million cases, followed by Russia and Brazil. So even the countries that have since had the infection, their numbers have peaked and the infections have declined, but only US seems to have a significantly ongoing outbreak that it's not clear when it will end, and particularly with the opening up of the businesses and other like increased movement of people, which can actually contribute to spread of the outbreak. These are some few things about SARS-CoV-2. What is known about the disease? We already know a lot more about the disease. We know that it's caused by the virus, and the infection causes a respiratory disease. And we have severity from mild to severe cases, and we shall see how that is. Some infected people have died from the infection, and these are people who have underlying medical conditions, what we are calling comorbidities. And these are the ones who are at increased risk for severe disease and severe death. What we don't currently know, this has been disputed, where is the disease, where it came from. We know a little bit how it's easily spread between people, but we don't know what puts some people at risk. Somebody can have up to 15 contacts, but not all of them come down with disease. So we don't know the specific things that put some people at increased risk, other than the close contact or the distance between the two, and the fact that there may be droplets moving between the two people. We know a little bit more about who's vulnerable to infection, but we don't know in terms of who's more susceptible to infection and why they're more susceptible to the infection. Currently, we know that people with comorbidities, when they get infected, they're at risk of severe infection. What we really don't know is that if you have a household of different people, whether the person with the comorbidities is more susceptible necessarily to the infection than the general population. What we know is that they will more likely develop severe disease. So the factors that we know are related to severe disease are being of male gender, being of an older age group, having comorbidities, and even within the comorbidities, the ones that have been shown repeatedly by several studies include comorbidities. Hypertension is high on that list. It's not very clear why hypertension would be highest on that list. And this is followed closely by respiratory comorbidities like chronic obstructive pulmonary disease, also patients with diabetes. We are looking for literature currently actually in Africa to see whether HIV patients are at increased risk of severe disease, but we don't as yet have that information. And particularly in sub-Saharan Africa, where we have the highest burden in the world of HIV comorbidity, then we have been watching that space to see whether our patients would be more vulnerable. We are looking to South Africa to provide that data, but currently that data is not yet available because either maybe the disease, the magnitude of the disease in the population is still low, because currently South Africa has just slightly over 15,000, between 15,000 and 15,000 cases. So we don't know how the disease would actually look like in HIV. Maybe the HIV patients have been protected by the lockdown strategies. As we all know, South Africa has had the lockdown, which was extended, and is having strategies to open up. So currently, maybe the vulnerable people have been protected from severe disease, but we wait for that evidence. But the ones that have been confirmed is definitely hypertension, diabetes, COPD, and some cardiovascular disease. How deadly is coronavirus? This is just a chart comparing the three highly pathogenic coronaviruses, SARS-CoV, MERS-CoV, and SARS-CoV-2. So when you look at, focus maybe on the SARS-CoV-2, again, first identified in China in November 2019. We don't currently know the host animal, but it's suspected to be the sea animals or the pangolin. It's not yet totally known. In terms of the global cases, we talked about the two previous outbreaks, and you can see the cases were very, very much fewer, and the outbreak ended before the cases became too many. But COVID became a pandemic, was declared a pandemic in March. And we can see now the cases have actually moved to more than 5 million total cases that have been confirmed, with more than 330,000 deaths. The mode of spread is more or less similar between all of them, and even the symptomatology. In terms of the countries that are affected, you can see that coronavirus is just affected about around 20 and 30 countries in the regions, but COVID has spread to 188 countries. The number of healthcare workers, when you have a very infectious disease, knowing the number of healthcare workers who are affected is important, because all of you are training to be healthcare workers, and therefore, by knowing this, it helps us to really focus on what is the risk to the healthcare workers and what can we do to protect the healthcare workers. So we know for the other two coronaviruses, there was a large proportion of healthcare workers who are affected because of nosocomial spread of disease, and particularly when you have a new disease, it can easily affect the healthcare workers because sometimes the infection prevention and control measures in the hospitals are not very well observed. So in terms of two, the jury is still out there. We have seen in China, the proportion of healthcare workers who are affected was about 4%. So China had about 88,000 cases, and 4% of those cases were actually healthcare workers who are affected. So close to around 4,000 healthcare workers were affected. When you look at Italy and Spain, a significant proportion of healthcare workers again were affected. We haven't really read the literature from the US, but again, I suspect there will be a significant proportion of healthcare workers who will be affected once the outbreak is finished. In South Africa, when I last reviewed the literature, they had about 555 cases of healthcare workers who had been affected. Yesterday, I saw an article from one hospital where 105 healthcare workers were affected. In our country, maybe we have close to 40, between 30 and 40 healthcare workers have been affected. And what you have to realize for the statistics in our country, most of these healthcare workers were people who are affected outside of isolation facilities because they were looking after patients who eventually turned out to have COVID-19. So they didn't have an early warning to protect themselves or to wear PPE appropriately. So the most important PPE, I think, for healthcare workers is your face protection. So having your N95 mask and having your face shield to protect you. In terms of the case fatality rate, you can see the highest case fatality rate actually was for MSAKE, where up to a third of the patients actually died from the infection. For SARS-CoV,
Sorry, Dr. Maiten.
yes,
Sorry, some static noises coming from your microphone.
okay, maybe my headphones. Let me steal my son's headphones.
Sorry.
I hope this will be better.
Yes, it's much better. Thank you.
Oh, it's so loud, the voice. I was really struggling with that answer. Okay. So when you look at SARS-CoV-2, we don't currently know the case fatality rate. It's estimated to be 3.4%, but this is because we don't have the true denominator. When you're calculating your case fatality rate, your denominator should be all cases that were affected. So all positive cases, regardless of mild symptoms, moderate, severe. So most countries have not been testing asymptomatic or mildly symptomatic. So that's why this case fatality rate seems to be at 3.4, but may even be much lower because we know that up to 80% of cases are mild to moderate, like asymptomatic to mild cases to moderate cases. So when you have a large proportion of people who are asymptomatic, and where the diagnostics only focus on people who are admitted in hospitals who get a test, those are the severe and critical. So you can actually overestimate the diagnostics. So most of the statistics, especially from the US, it's mainly derived from people who have presented to the hospitals because they don't have a lot of community testing for mild and symptomatic. And it's the same thing in the UK, where only people who have severe illness, severe enough to take them to hospital, are the ones actually obtaining a test. And like in our setting, where we are screening the truck drivers, we are screening healthcare workers who might have had an exposure, as well as even screening all the contacts of people who are currently in quarantine. So our statistics may give us a truer picture of the true infection, so that when you're calculating your case fatality rate, our case fatality rate from, let's say, yesterday's statistics would be the 50 dead cases, the dead, which is the 50 over the total who have been tested and are positive. So the ones who are slightly above 1,100. So that's how you calculate your case fatality rate. So if you have a situation where you're only testing your critical and severe cases, then your true denominator would not be accurate because you leave out a large proportion of people who are mildly symptomatic or asymptomatic. But just to highlight that SARS-CoV-2, of these three coronaviruses, SARS-CoV-2 had the highest case fatality rate. SARS-CoV had a lower case fatality rate. And particularly for the healthcare workers, for China, which had a high infection rate, once they confirmed that there was a person-to-person transmission, then no more healthcare workers were actually infected because they put in place very stringent infection control practices. And when you read literature of other countries like Taiwan, they actually had strategies. They stockpiled PPE because they suffered severely because of SARS-CoV-1. And therefore they put in place strategies to protect the healthcare workers and their healthcare system. by stockpiling personal protective equipment and other things for a future outbreak, which now they've deployed in the current outbreak. In terms of the pathogenesis for COVID, for SARS-CoV, it's thought to, this has not totally been confirmed, but it's thought to be mediated through the involvement of the immune response. So the COVID-19 acts on the lymphocytes, especially the T lymphocytes. And just like the SARS-CoV virus, the virus enters the respiratory tract. It multiplies in the upper respiratory tract. And that's why even in terms of your sample collection, you'll focus on the upper respiratory tract. And then it spreads through the respiratory mucosa and infects the other cells. So we'll talk about shortly, I think after this, the natural cause of the disease. But you have the febrile prodrome, and then you have a phase where the disease goes now to the respiratory, lower respiratory tract. So the mechanism for the disease in the lower respiratory tract is actually thought to be more the immune response to the presence of the virus rather than the virus per se causing the disease. So the infection of the virus particles induces, causes a cytokine storm in the body, which generates a series of immune response and causes changes in the peripheral blood cells and immune cells. And therefore, your patient actually moves from the stage of pneumonia to acute respiratory distress and septic shock, and eventually they get multi-organ failure. So when you're looking at your patients who have comorbidities, they're the ones actually who have this progression, because then they get the pulmonary phase and the ARDS and progress on to the multi-organ failure. So these are symptoms that you probably are already aware, and they are always said on the TV what symptoms to look for and all that. So fever, cough, dyspnea, headache, sore throat, rhinorrhea. In the data that we are collecting from our patients are actually having more sore throat than has been reported in the literature. We hope to publish our data, but our patients are actually having more sore throat compared to even other patients that have been described. So a large proportion of patients have fever. Some would have a dry cough, and some patients would report like an itchy discomfort in the throat. Some would have headache, some would have rhinorrhea. Some patients even have, we've had this in a few patients from Mombasa. They presented abdominal complaints that require them to have CT scans. And then when they're doing the CT scans of the abdomen, they find that the lungs are involved. And then when they test them for COVID, then they are actually found to have COVID. So although we are saying these are the commonest symptoms, in a patient who presents having that index of suspicion for saying it could be COVID, it's always good, especially now when we have this current outbreak. But what we have to remember, again, some other conditions can still present with this. So we should not say all patients are necessarily COVID. And when we don't find COVID, even from the test, then we stop thinking that they are unwell. We should think of other viral causes and the other differential diagnoses that can present like this. So the essence is not everything is COVID. The other diseases that were still existing still exist. So when do you suspect your patient to have COVID? So the possibility of COVID-19 should be considered primarily in a patient. In a patient with new onset, with new onset fever and respiratory tract symptoms, so your cough and dyspnea. It should also be considered in patients with severe lower respiratory tract illness without any clear cause. And we need to have an index of suspicion at the highest if we have a patient who meets the case definition. And I put this as to remind us of the case definition, which was the version that we had. It was last modified in March of 25th of March of this year. So it's a bit dated, but it still serves us. So what we know, majority of the people are not really traveling, unless you're talking of travel maybe from, let's say you're taking the history in Eldoret. If you have a patient who sneaked from Nairobi and have any of this, you have to suspect it could be corona, or they sneaked from Mombasa, you have to suspect it's COVID. If you have a truck driver again, then you have to suspect that they can have corona, and particularly if they're coming from Tanzania, where we don't know much about their outbreak, then you have to. So the context of travel, maybe a foreign country, but maybe also a county that has widespread transmission of COVID-19. So the travel is significant. You always want to ask about a travel from somewhere. And the moment they mention it, if you know the epidemiology of the disease in your country, then you can have that index of suspicion, or being in contact with a confirmed case. This is what the previous slide was talking about. When you have this patient who presents with severe respiratory illness, which is fever or cough or shortness of breath and requiring hospitalization in the absence of an alternative diagnosis, then you have to suspect that could be COVID. So how do you apply a case definition in your patient who you already know? Remember, your patient with comorbidity, you'll already know that they have that comorbidity. So because we say that those patients may be at increased risk of severe disease, if your patient has a comorbidity, hypertension, diabetes, then you always want to look for COVID, because they are likely to have severe disease. So even if they were exposed and they don't know, they're likely to come then to hospital with the features of pneumonia. So having that index of suspicion in your patient who's known to already becoming maybe to diabetic clinic or hypertension, and then you want to ask them whether they were in contact. So you're looking first for the respiratory presentation or an explained fever, and then going back to look for the epidemiological exposure, so that by the time you're meeting your patient, then you're having that index of suspicion that whatever is bringing them to hospital may be COVID on top of their comorbidity. So the comorbidity is playing a role in terms of unmasking the COVID that would otherwise, in a patient who doesn't have any comorbidity, would be silent. Majority of our patients are young. Majority of our patients have no comorbidities, and those are the ones who probably are skewing the statistics, where currently we have about 60% of our patients having asymptomatic or mildly symptomatic disease. And when we talk of asymptomatic disease, just to clarify, this is a patient who has no cough, has no fever, has no difficulty in breathing, is perfectly healthy. The moment your patient has any of those, has a fever, has a cough, has a sore throat, has a running nose, then you'll say they have symptoms, but then you have to categorize the symptoms and say, are these mild, are they moderate, or are they severe? So that's really how you apply the case definition. Then the other two is just different categories. So that if your patient undergoes a test, like we've had the 1,100 plus cases, and they're confirmed, then you say that they are confirmed cases, regardless of whether they have symptoms or not. Your probable case is your case who's in between confirmed and still a suspect, in whom you might find a test result comes back negative against your judgment. So you have a patient who has symptoms, but the results comes back negative. And this may be in situations where, for example, a lot of our patients who maybe progress on to severe disease, if you sample the upper respiratory tract, you might find a false negative. In such a patient, you might need to do a bronchoalveolar lavage or to obtain a test from the lower respiratory tract. So sampling your patient too late into their illness, you might miss the disease in the upper respiratory tract. So again, in such a patient, we've seen this in settings where a CT scan is done, a patient has symptoms, a CT scan is done, and the nasopharyngeal swab done is negative. But thereafter, when you do bronchoalveolar lavage or tracheal aspirate, then you find a positive test. So again, those are the description for the probable cases. These are the definitions of the contact. For you to have significant contact, you have to be in contact with a person face to face for more than 15 minutes and a distance of less than 1 meter. I'm emphasizing this so much because if you're a medical student rotating somewhere and then you come face to face, maybe you're doing a procedure for a patient or you're clacking them closely, you know, there you pull your stool and you're so in the patient's face. So you can actually have significant exposure. So if you don't have your mask and a patient doesn't have a mask, that contact, if your history taking is more than 15 minutes, then will be significant exposure. I was just using that example to describe what that means. And again, this is important to remember. If you're living in the same household, you'll find that sometimes you're eating together, your eating can take more than 15 minutes. So that's how clustering of infections can happen. There's a very good case study of a family that had dinner, I think in New York, like Thanksgiving dinner, and they all ended up having COVID and some of them died. I think majority of them died. So that family dinner was actually the exposure. So it's not to trivialize all these other exposures, but working with people, sharing the same space, again, creates that close contact. So what has really helped us is when you have your masks, because your masks reduce the amount of droplets that are generated when you're talking with other people. Traveling together with the COVID-19 patients, we've seen this happening, like the cases of contacts within the plane. Living the same household, this is very common now. We are seeing this in Old Town. We are seeing this even in Isili. So a lot of clustering within the household, and then healthcare associated exposure because of working in that setting. And particularly if you work in an ICU where you do a lot of procedures to generate aerosols, it puts you at risk. So the importance of this contact, again, remember your patient with comorbidity. If your patient has a comorbidity and is admitted in hospital, they can actually get health care associated COVID because they're in that setting. If the droplets are there, they'll actually inhale the droplets. So this is very, very important for us. And you had recently a directive to test a lot of patients who are in hospital to really help us identify, and particularly for our patients who have chronic non-communicable diseases like renal failure, who require chronic dialysis, coming to hospital frequently, using public transport. So that's traveling, using public transport, because you don't know in that vehicle who could be having COVID-19. So some of these things actually put our patients who have some of the comorbidities at risk, that if you have a widespread outbreak there and they have to come to hospital to obtain their medications and other things, they can actually get exposed. So when you have your patient who has been coming recurrently, has been using public transport, then they come with the respiratory symptoms, then again, your index of suspicion to think that they might have COVID on top of their underlying comorbidity, again, is very, very important. We recently, in our KNH webinar, we had a patient. She shared her story on Thursday this week. She is a business lady. She has a comorbidity, she has HIV, and she went to shop in Isili to buy some things. And then she developed symptoms a few weeks later, and she went to CCC, and she actually turned out to be COVID-19 positive. And she infected, I think, 3 or 4 people in her household because of that. So it's difficult to tell whether having HIV as a comorbidity put her at increased risk of susceptibility or getting the infection. But definitely she transmitted the infection to about 4 of her family members. And many of them actually just had mild disease. So they didn't develop severe disease. She had moderate disease because she had moderate symptoms, but she didn't need any definitive support, including like oxygen or ventilatory support. She had a good outcome. She's actually been discharged. When you have your patient, this again will apply with your patients with comorbidities. So the incubation period for COVID-19 is anywhere between 2 and 14 days. It's even thought to be as high as 21 days. And the importance of this incubation period is when we are following people in quarantine, we follow them for 14 days, but we ask them that should they develop symptoms thereafter, then they should still consider that that could be COVID. So people who are quarantined are people who have been in contact with a positive case to see, and the period of quarantine is to observe to see if they've developed the symptoms. So the incubation period is that time between exposure to development of symptoms. And what you're watching out for are the symptoms, the fever, the cough, the fatigue. Your cough can be dry most often, but you can also have sputum production, headache, hemoptysis, diarrhea, dyspnea. This is not a symptom, it's a lab finding. The period from onset of COVID-19 symptoms to death, from literature from China, from even US literature, is anywhere between 61 to 41 days. So some patients die very early, and the patients who die very early are actually the patients who have comorbidities. So a lot of the patients who have comorbidities are dying shortly after. It's almost like they're dropping dead because they have a shortened cause of illness, a very fulminant disease, and they die longer. Some patients are staying longer to 41 days, but these are the patients who are going to mechanical ventilation. So what mechanical ventilation does is just to prolong like death, the time to death. But on average, most patients who die from COVID-19 die over a period of 14 days. So when we look at our data, we have about 50 patients who've died. Majority of the patients who've died have actually died in Mombasa. And majority of them even have died shortly after being admitted in hospital because they stayed for too long at home, because people fear the stigma once you have a confirmed case, what happens to your family? What happens to the rest of the people you're in contact? So a lot of people have shunned going to hospital and therefore have had a poor outcome. Some of the other patients, there was one patient at the KU hospital, the Kenyatta University Hospital, that one he had a comorbidity. He went to hospital when he already had pneumonia, but he was in hospital for slightly over close to a week, and then he died. So most of the other patients have been in between. Some of the patients died shortly after admission. So we haven't had a very dramatic presentation to hospital where we have followed up so many patients, have had to ventilate so many patients, and therefore have had a time to study a lot of these patients. But it's important as the outbreak continues to grow, then we might have more statistics, and we hopefully want to understand more about the patients who are dying, because once we know the profile of the patients who are dying, it will give us an idea of how we can prevent those deaths by protecting maybe the at-risk population. So far, in terms of the death, in our statistics, most of them are male patients, most of them are older, like above 60 years, but we also have some children, I think one child who died and he had a comorbidity. The COVID was actually diagnosed post-mortem, like after he had died, because of the presentation. So again, too early in our outbreak to analyze a lot of the deaths significantly. But to say also, of the recoveries, we have slightly under 400 recovered patients who have been discharged. Some of those recoveries are patients even who have comorbidity. Yeah. So I know many of you want to hear a lot of adverse effects related to comorbidities, but we have a mixed bag where some of the deaths are related to patients with comorbidity. Some of the deaths are related to, some of the survival are still related to patients with comorbidity. So at this point, it's a bit difficult to say what puts some people at risk of dying. Is it the late presentation? And what protects some people even with comorbidity? Because the difficulty is many people with comorbidities now are very scared. They are probably staying away from hospital, and that can have an adverse effect because then they will not have their medications for example, their diabetes. They'll not have their medications for example, the hypertension, because they don't want to come into contact. So again, the kind of messaging we send out there should be balanced so that we are not scaring the people, but also to have a system where we can follow up these patients and reach them and actually provide care to them, maybe even at the community. So the period, again, of symptoms to death is dependent on the age of the patient and the status of the patient's immune system, with more patients who are in the older age group having a shorter interval to death. So it's shorter for patients aged more than 70 years old compared to those under the age of 70. So this is data mainly from the developed world, like particularly in the USA. They have an older population by and large, or they have more people who are older, and these are the ones who've had an adverse outcome. So when you look at, I know this talk is mainly about comorbidity and its impact, but when you talk of, just like in cardiovascular disease, we talk of modifiable factors and non-modifiable factors, and particularly for COVID-19, there are two non-modifiable factors that clearly stand out as adverse outcomes, and that is being of male gender and being of advanced age, which again, you cannot say age is a comorbidity. You cannot say being of advanced age is a comorbidity. So already people who are male and who are of an age more than 60 years old are at increased risk. And that's why in one of the earlier directives, the president actually recommended for people who are aged more than 58 years old, because we know that in our country, life expectancy is lower. I think it's about 55, I'm not sure. Some of you might know that better. So we don't have too many old people, but in that directive, we actually recommended that for people who are older than 58 years, they actually work from home because age is a risk factor for severe disease. And even in our hospital guidelines, for patients who, for doctors like our older colleagues, we're actually recommending, we are deploying the young workforce to the field because we want to protect them. Should they get COVID, they're likely to have an adverse outcome because of being of older age. So in our country, maybe you are more strict because we've selected 58, and many of you would think that 58 is old. I'm closely following, like headed towards that age. So it's a good thing that the president has provided that guideline to sort of like protect the old. But definitely data from the West has shown that people who are more than 70 years old are likely to have an adverse outcome. The severity of a clinical picture, again, is correlated with age, more than 70 years old from the data from New York, and comorbidities like diabetes, chronic obstructive pulmonary disease, hypertension, obesity, again, is there, and then male gender. But currently, there's no scientifically valid explanation that have been developed to explain some of these associations with the adverse comorbidity and even severity of the clinical picture. I forgot to mention earlier when I was talking about the pathogenesis, but for the coronavirus to enter the cells, it requires, it uses the angiotensin converting enzyme 2 receptors. So it's been postulated and that patients who have some of this comorbidity and be on certain treatments, like if they're taking ACE inhibitors or ARBs, they're likely to have an adverse outcome, because when you take those agents, you block the receptors, and what the body does, it tries to upregulate, so it prepares more receptors. So it's thought that patients who are taking ACE inhibitors may be the risk factor that the receptors are upregulated and more, and therefore provide an entry for the virus to enter different systems, because the receptors are mainly found in the lungs, they're found in the heart, they're found in the blood vessels and in the kidney. And when you look at the multi-organ failure that occurs in COVID-19, it seems to follow those organs, and therefore it's been thought that the receptors may play a role. And some people even have thought that maybe in Africans, that's what is protective, because when you look at some of you maybe who are in older years of medical school, we know that for treating hypertension in Africans, the ACE inhibitors are not useful because the receptors are too few. It's like we don't express the receptors fairly well. So again, that needs to be proven to see whether there's a receptor polymorphism that protects the African population from the effects of COVID-19 and even infection per se, because the receptors are too few to cause infection. But again, this is not yet been fully explained, and we await further research. So this is just an illustration to explain from the incubation period to the clinical symptoms, clinical signs, and even adding the experimental treatments that have been tried for the patient. So you have 3 phases of the infection. You have stage 1, which is the early infection, mainly the upper respiratory tract prodrome. Then you have the pulmonary phase, which is stage 2, again happening in the lungs. And then you have stage 3, which is hyperinflammation phase, which is now systemic or the cytokine storm. So when you're looking at the viral response, the virus is highest in the early infection. And as the time progresses, the level of the virus declines. And therefore, when you sample your patient in stage 3, you're unlikely even to find the virus. Those patients are less infectious because the virus hasn't started the process but has escaped. So it's the immune response that is actually responsible for the clinical presentation. When you look at the host inflammatory response, it starts to peak after the early infection. It starts to increase after the early infection during the pulmonary phase, with the highest level being in the hyperinflammatory phase. So for the hyperinflammatory phase, this is mediated mainly by interleukin-6, and some of the interleukin-6 receptors have been tried to manage the patient in this phase. But again, all the treatments have been experimental. In terms of the clinical symptoms, in the early infection, you have the mild constitutional symptoms. And remember, again, some people can be infected, but they don't have any of these symptoms. So in terms of the fever, you have fever more than 37.5 degrees. You have the dry cough. Some people have diarrhea, particularly in children. Some people may have the headache. So you have what is called the flu-like illness. When you have the pulmonary phase, the main presentation there is shortness of breath and hypoxia, manifested by this reduction in the ratio between the partial pressures of oxygen and the fraction of inspired oxygen, which is less than 300 millimeters of mercury. And then in the hyperinflammatory stage, you have the acute respiratory distress syndrome, severe inflammatory syndrome, shock, and then cardiac failure. So all these are manifestations of the effect of the cytokine storms. In terms of the clinical signs and laboratory manifestations, you have lymphopenia, increased prothrombin time, increased D-dimer, and increased LDH in mild disease. For your pulmonary phase, mainly you'll have a lot of imaging abnormalities, and we'll discuss this. You'll have involvement of the liver and elevations of the transaminases. You have the low to normal procalcitonin. And then in terms of your inflammatory stage, you have elevated inflammatory marker, which we don't really assess in our setting. A lot of this, CRP, LDH, IL-6, D-dimer, and ferritin. Even your troponins and antitroponins are also elevated because they get a myocarditis as part of the inflammatory response. These are potential therapies, but we'll mention them towards the end. But just to remember, nothing yet works. So there'll be nothing magical, even you'll give your patient who has comorbidity to prevent them from progressing. It will mainly be supportive treatment. So this is just a very quick summary of the manifestation. In terms of duration of symptoms, your early infection can last anywhere for about a week or slightly more than a week. Then in the second week, you go into the pulmonary phase. And then around your third week, then you get hyperinflammatory phase. So when you're getting our patients who are presenting very late with respiratory symptoms, then you're likely to be getting them about 10 days since their symptoms actually developed. And then you read some of the case reports from people who've recovered or people who have gone through COVID-19. Some patients actually tell you when they go through the early phase, on the day they feel like they're getting better and they're recovering, then all of a sudden they develop this difficulty in breathing they cannot explain. And actually that is the most dangerous phase, because sometimes in some of the settings where patients are doing home isolation or home-based care, you can actually be in a house and you're so helpless, you cannot talk, you cannot breathe, and some patients can actually die suddenly at home. When it comes to, I've given an idea of the temporal relationship. What you have to remember is your patients who have comorbidities, they actually have a fairly rapid progression. So instead of this being a week, it can just be a few days. You can have 3 days, then you go into the pulmonary phase within 3 days. So the disease is fairly shortened and more progressive. And that's why for the guidelines that we've given out, and even when you do our CMEs, we actually emphasize that for patients who have comorbidities, those are the ones, once we identify them, we want to manage them in hospital, because in hospital, we can actually pick up the hypoxia. We'll be monitoring their partial pressures of oxygen, and we'll be able to pick up the hypoxia and therefore intervene. And in some cases, actually, in patients who have comorbidities and they develop early hypoxia, you can give them preemptive oxygen therapy without necessarily ventilating them. So you give them oxygen through nasal cannulas, high flow oxygen through nasal cannula, and you sort of help to recover the lung function instead of it deteriorating. So again, that is an important thing to note, that for patients who have comorbidity, we'd not want them to stay at home. We'd not want them to manage their illness at home or try to stay at home without coming to hospital, because we know the rapid progression of their illness, their risk and predisposition to severe disease. We'd want to monitor them closely and watch out, so that if they go into the pulmonary phase and progress on, then we can institute some of the ventilatory support to prevent imminent respiratory failure. So in terms of diagnosis of COVID-19, I'll not belabor, you already know most of this. The diagnostic of choice is reverse transcriptase, PCR, because you want to identify the nucleic acid of the coronavirus. And this is in the nasopharyngeal and oropharyngeal swabs to obtain this, the virus in the upper respiratory tract. If your patient presents late, like in the pulmonary phase, or having symptoms of pneumonia, and you get a negative swab result, you can go ahead and obtain a lower respiratory tract sample and send it for analysis. So while we are at this point, because some of you might start practice and corona might still be there, this procedure of obtaining the sample is a high-risk procedure, and you need full protection. full PPE. When you talk of full PPE, you have an N95 face mask, you have a face shield, you've covered your hair, so you can wear the hazmat suit that's like a jumpsuit plus a hood. You have your mask, and then you have your face shield to protect you. And then, of course, the gloves for the hands and shoe covers when you're going to obtain this sample. So it's a high-risk procedure. Anything looking into the airway, if you're intubating a patient, if you're obtaining the sample, we consider this a high-risk procedure, just like going into the isolation unit. So you have to wear full PPE. Once you obtain the sample, then you send it for diagnosis for the reverse transcriptase PCR. If your patient is in the respiratory phase or a negative sample in a patient who you highly suspect, then you can obtain some of these samples again. And even where you're obtaining some of these samples has to be in a negative pressure room, because you can generate aerosols that can come or can linger in the atmosphere and put other healthcare workers at risk. Viral RNA is higher and more frequently detected in nasal compared with the oral specimen. But in our current guidelines, you obtain 2 samples. You pass the nasopharyngeal swab straight to the nasopharynx, you obtain 1 sample. Then there's a shorter swab for the oral pharynx, and you put both of them in the viral transport media. So in our sample collection, we send 2 samples for every patient that we send. If initial negative testing but suspicion of COVID-19 remains, then WHO recommends resampling the patient from and obtaining the other respiratory tract samples. These are additional lab findings that you'd expect. And in our guidelines, we haven't made provision to do a lot of these things because most of the isolation units that we have prepared are actually in very resource constrained. So to minimize the risk for the other patients and the other things, we haven't recommended a lot of invasive investigation. But because I'm teaching you this is like a class teaching, then I'm giving additional information beyond what is even in the guidelines. So you need to do a blood count, and what you'd find is that your white cell count can vary. But patients who have lymphopenia are likely to be the ones with severe disease. So likely that our patients with comorbidities are likely to have low white cell count. Most patients have elevated lactate dehydrogenase and ferritin levels. Most patients would have mainly elevated aminotransferases, so the AST and the ALT, which would suggest liver involvement. So in patients who present with the pneumonia, in settings where they're able to do calcitonin, most patients would actually have a normal serum procalcitonin. So a procalcitonin is a point of care test that we use mainly to tell us, to help us know if the cause of the respiratory disease is bacterial or viral. So bacterial disease will be associated with an elevated procalcitonin level. Viral diseases normally are associated with normal procalcitonin levels. So for patients who come with COVID-19, the expectation is that the procalcitonin level is likely to be normal. But for patients who require ICU, sometimes you can have an elevated procalcitonin level, which can mean 2 things: that maybe your patient already has the severe disease, or even could have a super infection by a bacterial infection. And even when you have a patient already in ICU, when you have a high procalcitonin level, it may suggest to you that they have hospital-acquired pneumonia, so a super infection because of that risk of maybe mechanical ventilation or intubation. The D-dimer, the D-dimer is likely to be elevated, especially in patients who have severe disease. And this has been found even in other settings, like in New York, and newer publications now are suggesting that most patients actually complicate. When they go into the SARS, then they develop a hypercoagulable state and they have thrombosis in multiple vessels. And therefore, when we see an elevated D-dimer, it suggests a severe disease. And these are patients from other settings who eventually actually die. So it's a terminal event, having the D-dimer and lymphopenia. But because we already know this, then we know that some of the patients, we may need to prophylactically anticoagulate them to prevent the multiple thrombosis or hypercoagulable state. In terms of, and what is recommended for the anticoagulation is actually unfractionated heparin has been found to be superior to low molecular heparin. In terms of imaging findings, this again is has been done, we've gotten a lot of case series from severe, in settings where there's been severe disease, and most of the CT, and even China shared a lot of their CT images. So what we know about CT scan findings can actually precede even a positive RT-PCR. So even before your patient has significant detectable viral load in early infection, they can already have abnormal CT scan, and this is really an unexpected finding. So what is commonly demonstrated in CT scan is ground glass opacification with or without consolidative abnormalities. And what we note on the CT scan is likely to be bilateral, have peripheral distribution. So peripheral is more on the sides and then involve the lower lobes. I didn't include a CT scan in my presentation, but before I share the slides, I'll look for the following slide. I'll put a lot of CT scan just to illustrate a normal CT scan and a COVID-19 CT scan, just for your reference. Less common findings can be pleural thickening, pleural effusion, and hilar lymphadenopathy. So this is a very good case series that I'll share with you the full article. And this is, I think, the largest. Initial studies from China had 41 patients, maybe 170 patients, but this is the largest series. And this is a series that was published on April 22nd in JAMA. And it was looking at 5,700 patients hospitalized with COVID-19 in the New York area city. Many of you probably, if you watch CNN, have seen the outbreak unfold in New York City. So at the highest peak, I think they used to have 1,000 deaths for several days in a week. But the outbreak, I think, seems to have passed by the severe, like the peak of the outbreak. So in this series, they described presentation of 5,700 patients who are included. And the series actually followed up patients from 1st of March to around 22nd of April in several hospitals in the New York area. So a little bit about the US outbreak. So in the US outbreak, only sick patients would be sent to hospital or would be admitted in hospital. Patients who have mild disease or asymptomatic disease would be encouraged to self-isolate at home, but would be educated on what to look for to say that they are progressing and would need additional care, would need to go into hospital. So when you look at this data, it's very skewed, that it's focusing on the severe and critically ill patients. So in this series, the mean age of the patients was 63 years. Okay, let's continue. So the median age of the patients were 63 years with a range of 0 to 107 years. Many of them were male. Just about 40% were female, so about 60% were male. And the most common comorbidities were hypertension in 56% of them, obesity in 42% of them, and diabetes in about 34% of them. And basically, they followed up these patients to see different outcomes. And the outcomes that were possible were either you've died, you've been discharged, or you are still like in hospital. And from the statistics globally, the rate of recovery is a bit slow. And the recovery is defined as having 2 negative tests within a period of 24 hours after all your symptoms are declined. So there's a lag time between the recoveries and the people who are sick. Like when you look at the global statistics now, with more than 5 million people, you just find like a small proportion of people have actually recovered. So they assessed the outcomes for 2,634 patients who are either discharged or had died by the study endpoint, which was around 22nd of April. So on this table, we're looking at the total number of cases, and this is actually the distribution of the comorbidities. So about 6% of the patients had cancer, about 56% had hypertension, 11% had coronary artery disease, about 7% had heart failure. And then in terms of respiratory comorbidity, this is close to 9 plus around 8. So around close, slightly under 20% had chronic respiratory disease. HIV was a small proportion, but also HIV in the US is not very, very common. And then 1% had history of solid organ transplant. Then we see the different comorbidities in these patients. So again, what this tells us is that a large proportion of patients who are sick enough to go into hospital had different comorbidities. And therefore, even when we have a very widespread outbreak in our setting, this will more or less reflect the number of people who will be seeking healthcare, because these are the ones who will develop severe disease, severe enough to require hospitalization. And therefore, we need to be looking out for some of these comorbidities. But I think for us, because we don't yet have a widespread outbreak, what we should be putting our heads together to think of is, how do we protect our most vulnerable? Because if we're looking at our most vulnerable, then our most vulnerable: patients with hypertension, patients with chronic respiratory disease. Our HIV patients would fall into that category because we don't know too much about it, whether they'll suffer a severe disease. And therefore the question, and this I'm posing to you because you guys are part of MSAKE, you're the people who would have solutions for the future. What are some of the innovative ways that we can do to shield these people from coming into contact with the disease, be it at the community, be it at the household level, be it at hospital settings? So should we have ways of getting their medications to their houses? Should we have home-based care where they're the ones actually being attended to by healthcare workers, but we screen the healthcare workers going to visit them? Should we create facilities where we confine all of them, we test them and confine them and screen everyone who's going to look after them, so that we are segregating them from the general public? And would that be a feasible way than trying to say that let them get infected and then we see how many of them maybe recover, how many of them survive? Because we know for COVID-19, we currently don't have a cure. We don't even have a vaccine. The only preventive strategies are public health preventive strategies. So how do we protect our most vulnerable to prevent statistics like we're seeing in New York? So let me continue that case study. So in terms of following them up after they were hospitalized, these were some of the outcomes of the hospitalization. So about 14.2% of them, which were just about 300 of them, were treated in the intensive care unit. And some of these received invasive mechanical ventilation, so 320. So the difference of about 53, those ones were not mechanically ventilated, but received some form of oxygen therapy. Out of these 373, about 3.2% were treated with kidney replacement therapy, because one of the adverse outcomes is actually they go into acute renal failure. So about 3.2% of them received some form of kidney replacement therapy. 553 had died at the time of the follow-up of the study. And remember, once your patient dies, then they achieve that outcome of interest, because your outcomes are either dead, maybe discharged, or still in hospital. So you have three potential outcomes. So within that follow-up period, a significant number of them had died. As of April 4th, which was still within the follow-up period, patients requiring mechanical ventilation were too many. They were about 20.2%. Remember, we started off with 5,700. So about 20% required mechanical ventilation. And of these who received the mechanical ventilation, only 38 were discharged alive, so 3.3%. 282, despite mechanical ventilation, died. And 831 remained in hospital. And what does that mean? They remained in hospital, they were still in ventilator, because even when you're in hospital, you will need that ventilator. So looking at this statistics, this is really important for us. In this country, we have about just 500 ventilators. New York only, they had these patients who required mechanical ventilation. And even for the ones who went on to mechanical ventilation, 831 remained in hospital and were most likely on the ventilator. So for us, ventilator will not be a therapeutic option, will not even be a supportive option, because in the whole country, we don't have too many ventilators. And COVID is one disease that requires ventilator. Your patient with head injury, your patient with other respiratory failure would require the same ventilator. So how will you rationalize the ventilator? And what we can actually see is that the ventilator does not cure. It's just a supportive treatment. It's not a definitive treatment for COVID-19. It's a supportive treatment. And what it basically means, even from data now that has come out from New York, the ventilators basically delay the death, because eventually some of these patients get ventilator-associated pneumonia. Some of them become ventilator dependent and cannot even be weaned off from the ventilator. So you have 72% of the patients staying on to the ventilators, and therefore it means it will not be sustainable because a lot of the patients will not get the ventilator. Let me switch on the lights, please. 1 minute. Sorry. So what this means is that your resources in a low resource setting may not be enough to support a lot of the patients who will be sick enough to require. And that's why in my previous slide, I delivered what do we need to do to protect and manage our resources to have a good outcome for the patients who will be most vulnerable, our patients who have comorbidities. In terms of the follow-up period, the median post-discharge follow-up time was 4.4 days. So these patients who were discharged, they were followed up for 4.4 days. But what was again very unfortunate, a significant proportion, 2.2% of those who had been discharged were readmitted during the study period. And we've had case reports of patients who went home and came back. Some of the ones who came back actually died because they went, some of them went home fairly too early before the cytokine storm stage. And when they came back, they were too sick and some of them succumbed before anything could be done. The median time to readmission was 3 days. So they were just home for 3 days. And among the 3,066 patients who remained hospitalized at the final study follow-up date, they were still the older age group. And they had been followed up for 4.5 days before the study period came to an end. So basically what this means is that for most, in our setting where we're in a resource poor setting, we already know from the West who are the most vulnerable people. We know about the disease, how it presents. We don't have a cure. We don't even understand too much what's the pathogenesis of the severity of disease in those patients who are most vulnerable. But what we need to think of is public health strategies to separate the most vulnerable from the ones who can actually develop to keep the disease away from our most vulnerable population. This is just the characteristics of the New York study still of the people who had comorbidities. And you can see majority of their patients had multiple comorbidities. So you might find the hypertensive patient still had chronic respiratory disease, or a hypertensive patient still was a cancer survivor. So about 88% of the patients had more than one comorbidity. And this is significant because we don't know too much whether having two comorbidities doubles your risk of COVID-19. So in terms of approach to management, these are just general things now. We don't have any specific antiviral treatment. No vaccine is currently available. For patients who have mild symptomatic disease, so when you talk of mildly symptomatic, these are the patients who have mainly upper respiratory tract signs, so they can have fever and a bit of discomfort in the sore throat. So we focus on preventing transmission to others, isolating them, and then monitoring them for clinical status, because we know that this is the early phase of the disease. They can still progress to the pneumonia phase. So we need to monitor them by measuring their temperature, blood pressure, oxygen saturation, and respiratory symptoms for 14 days. And this is what we do in the isolation units, even when we have isolated these cases. And the main reason for isolation in our setting is because we learned a lot from the China outbreak. A lot of the disease occurred in household. And some of you might have had discussions about home-based care. And we are currently looking at the guidelines to see how to safely maybe advocate for home-based care. But for home-based care to be successful, the person really has to have an environment where they can isolate themselves in their home and prevent transmission to others, your family members, basically. So you're in a house, but you don't want to infect your household members. So that is one consideration for people who might be mildly symptomatic or even asymptomatic, because asymptomatic people are still infectious. The treatment is symptomatic if somebody has mild symptoms. Oxygen therapy represents the major treatment for patients who have severe infection, and I'll talk about it shortly. Mechanical ventilation may be necessary in case of respiratory failure refractory to oxygen therapy. So this is non-invasive oxygen therapy. If that fails, then you might need to do mechanical ventilation. But from the data of the New York study, ventilation is not the way to go because you may not be able to wean the patients off the ventilator. And most patients on average, remember in an earlier statistic, in an earlier slide, I mentioned that the time from onset of symptoms to death was on average 6 to 41 days. For the 41 days, it's actually patients who are put on ventilators and stayed on ventilators for up to 3 weeks before they died. So it means even the few ventilators you have will not be enough because many of the patients will be staying longer on those ventilators. So the high turnaround time will be slow for few resources that would be there. Hemodynamic support is essential for managing the septic shock, which is the last phase of the illness we saw in stage 3. In terms of managing severe disease, COVID patients with severe disease are managed supportively while ensuring appropriate infection control. And in terms of oxygen support, you can use either high flow oxygen through nasal prong or non-invasive positive pressure ventilation. Some patients who develop acute respiratory distress syndrome may warrant intubation with mechanical ventilation, and in extreme cases, they can have extracorporeal membrane oxygenation, which is available in very few settings, even in very developed countries. And this is where you actually, when your patient has the ARDS, then you try to use membrane oxygenation devices to supply the oxygen and oxygenate the blood. So again, very resource intense, not widely available. In this country, we don't even have that. So this prognostic tool was developed originally in China. It's not found widespread use, but I think it can be revisited. But basically, it's after the SARS outbreak of 2002, they tried to characterize the patients who died in line with the early warning model for predicting mortality in viral pneumonia. And basically, for this prognostic tool for COVID-19, these were the 6 indices that they found very significant. So having multilobular infiltration on CT scan, having lymphopenia, having bacterial co-infection, having had a history of smoking, having hypertension, and age. And all this were actually found to have the highest predictive score of the patients who died. So even when they applied it for one of the earlier publications in China, they actually found that this score actually sort of predicted the patients who are likely to die, especially if they scored on each of these categories. They had a very high score of dying. Antiviral therapy, to summarize these slides, all treatment that is currently available is investigational. None of them has been confirmed to provide any like significant contribution or effect on COVID-19. And therefore, what is recommended is for enrollment of patients into clinical trials, should anyone want to use any of the treatment. We currently don't have any controlled, very well studies done on randomized controlled trials to support using any of these agents. Remdesivir is very, very promising, although people have said the studies that were published were a bit skewed and they were not controlled, and these were given to patients on compassionate use, and the patients who received them were the ones who are likely to die, and therefore you don't have very good controlled trials to support that. So we need more evidence to support that. This is a list of the experimental treatments. Some people have tried corticosteroids, remdesivir, chloroquine, hydroxychloroquine in combination with azithromycin, tocilizumab, lopinavir, ritonavir, baricitinib, NSAIDs, and ACE inhibitor to angiotensin converting enzyme 2. So all these have been tried, but none of them so far has really been approved for use in COVID-19. And therefore, even when we want to use it in our country, we are using it in the setting of clinical trial. We are currently reviewing the clinical guidelines because it had given room for use of hydroxychloroquine, but there's a new publication even that has come out to suggest that it may cause more harm than benefit. So we are enrolling into a large clinical trial supported by WHO and Ministry of Health to try some of these drugs. So supportive therapy, we've talked about oxygen. Oxygen may be the most important thing for us currently in terms of managing COVID-19 patients. And for most of the facilities we're trying to mentor is really to encourage them to have oxygen in high quantity. So even to have oxygen plants, because a lot of patients would need supplemental oxygen. And if you give the oxygen early, you can preempt the need for mechanical ventilation. So you can use high flow nasal oxygen in selected patients, and it seems to be better than standard oxygen therapy. Non-invasive ventilation, patients treated with either high flow nasal oxygen or non-invasive ventilation should be closely monitored for clinical deterioration. So you need to do your pulse oximetry and other vital signs. Patients who come with hypercapnia, hemodynamic instability, multi-organ failure of abnormal mental status should generally not receive high flow nasal oxygen, but should be reviewed for possibility of mechanical ventilation. So these are patients who are very sick and actually would be in severe pneumonia, tending towards critical pneumonia or like requiring critical care. So again, these are the ones who should be assessed for mechanical ventilation. So these are basically what these 2 points are talking about. So far in our patient population that we have looked after, most of our patients we actually, within our Mbagathi facility, we've not had patients who've required oxygen therapy because we are picking up the patients fairly early. We currently have the facility within Kenyatta, the former infectious disease unit. It's been converted to an 8-bed critical care unit, and that will be available for patients who need high flow, who need mechanical ventilation and critical care. So already we have that facility, but the facility of the Kenyatta IDU that's currently in Mbagathi is taking a lot of patients who are mildly symptomatic. The ones who have moderate symptoms none of them has required, but we do a clinical assessment, and should patients require, like their status is changing, that they cannot benefit from the high flow nasal oxygen, then we are sending them to the KNH facility for mechanical ventilation. But so far, we've been very fortunate. Most of our patients have been fairly stable and have mild disease. But as the outbreak unfolds, it may not be like that for too long. So we are already making preparations, and even the 10-bed, the 8-bed critical care unit may not be enough. And that's why we are working closely with KU Hospital and other hospitals to see how we can support patients should we have a surge of the outbreak. In terms of supportive therapy, again, for patients who have a high D-dimer value, then they benefit from anticoagulant therapy. This is, unless it's contraindicated, then they benefit from anticoagulant therapy. But in the guidelines, we have not made a recommendation for generalized anticoagulation. It's based on the clinician's assessment. In terms of the antipyretic to use, paracetamol is what is recommended. NSAIDs are relatively contraindicated. From earlier studies from the French outbreak, they actually found that patients who took NSAIDs had a worse outcome. So currently, the antipyretic of choice in our guidelines is paracetamol. This, I think, is my last slide, just to highlight the preventive strategies, which already, I hope all of you are adhering to this, because in the absence of our vaccine or any other therapy, this will be the only things that will protect us from getting COVID. Using face masks, covering our coughs and sneeze, washing hands regularly, avoiding contact with infected people, maintaining appropriate distance, refraining from touching eyes, nose, and mouth, and then seeking care early. So on my day-to-day practice, the most important is my face mask. You have to wear your face mask. Do your hand hygiene, wear your face mask. And then when you're out in the public, if you're going to do, like when I go to see patients like in Mbagathi Hospital, I wear a face shield on my rounds and I have gloves. But between patients, what I do is hand hygiene. And the whole day, I'm not touching my eyes, I'm not touching my nose, I'm not touching my mouth. If you have to remove your face mask, like many of you probably are driving around town, you remove your face mask in the car, you must have your hand hygiene somewhere in, like your hand sanitizer in the car. Before you touch your face mask, wash your hands. Before you put on your face mask, again, wash your hands. So washing your hands, you can wash your hands up to 100 times per day. I think that's the most important thing. And if you do those things and you're not in contact with an infected person, you're keeping your distance, then you are unlikely to get infected. So this is a message I hope all of you have educated your families, because again, most people who have COVID-19 in Kenya are asymptomatic. So we'll not be waiting for somebody with symptoms to infect us. Somebody can come, they'll not tell you they have COVID-19, they've been exposed, and then you get COVID-19. But if you keep on washing your hands, keep on wearing your face mask, then your risk for getting COVID-19 is significantly reduced. And I think that is what has made a difference in our African countries, especially the East African countries, because we had the lockdown measures and then we've introduced the face masks and we're asking people to do hand hygiene. The only thing is our lockdowns now are being eased, so the outbreak might still increase. So this is my concluding slide. COVID-19 epidemiology is still unfolding. We have some insights into who may be high risk in terms of our comorbidities, but these are people who are part of the general population. So our hypertensive, our patients with respiratory disease. But whatever we do, understanding the epidemiology of COVID disease in the general population is very, very important, because whatever we do in the general population still applies to the high-risk people. What is important to know for our high-risk population is that they are likely to develop severe disease. And even when they get the COVID-19, there'll be no magical treatment we'll give them. So the most important thing in my perspective is to protect them and shield them from coming into contact with infected cases. So preventive strategies are still important in limiting the spread for COVID-19. Thank you. That was my last slide.
Thank you very much, Dr. Maritim. Indeed, that was a very informative and insightful presentation. And as medical students, we now understand that COVID-19 is beyond just washing hands, having a dry cough or fever. It is a lot more. And of course, this information is not available in any textbook in the world. So thank you very much for the really interesting summary of what's going on out there. And of course, as we are unfolding and this virus is growing within our nations, we hope to play our role, our part as medical students. Now, before we go into the question and answer session, because we have many students who want to ask questions, we'd just like a quick icebreaker just for 5 minutes, just to refreshen our minds. So I'm just going to share my screen, just a minute. Okay, so can you see my screen? Ruby, can you see my screen?
Yes, we
All
can.
right. Okay,
Yes, yes, I can.
so I'd just like you guys to go to www.menti.com and then use the code 20132 and just tell us what's the best book you've ever read, just before we go into the Q&A, so we can have a quick icebreaker and refresh in our minds. So menti.com and use the code 20132. Ah, interesting. Even if it's a Ganong or a Bailey's or Robbins, please put it. It's still a book. Kadzong, interesting. Okay. Robbins, my favorite. Okay. I'll give it another 3 minutes. Oh, another favorite, When Breath Becomes Air. Another 2 minutes. Okay. Thank you everyone. It's good to see that we read books other than medical books. I mean, that's a really good habit, and I can see we have surgeons among among ourselves, because when breath becomes air, that's cool. That's really interesting. Thank you very much. Yes, Dr. Maritim, which is your favorite book?
I was even thinking of a favorite book. I was trying to make up one before you asked me. I don't have any.
Thank you very much. Now I'll hand over to Patrick, who will take us through the Q&A. Thank you.
All right, thank you so much. Yes, can you hear me?
Yes, we can hear you.
Hello, yes. All
Yes.
right, thank you so much. All right, thank you everyone, and especially Dr. Ari, thank you so much for joining the call and for the knowledge you have shared. Indeed, it's something we couldn't find from, ordinary places, but we are glad to have you. Some of us are happy to see, we saw you on our screens, but you really are an amazing person. And just to introduce ourselves to this question and answer session, we have already received responses from a lot of students who are actually sending appreciation already for the kind of information you have shared with us, and that is pretty good. So we have a couple of questions, and I would ask all our participants to keep on sharing their questions. Yeah, so Dr. Ari, the first question we would like to ask is regarding a patient you mentioned in your presentation, a pediatric patient who passed on the 11th of April and whose COVID status was diagnosed post-mortem. So regarding this question, I just like to ask, especially because the patient had a comorbidity. So the question is, what is the chance that we are missing, or what is the chance that we are affecting our COVID data with the numbers which are resulting mainly maybe from other diseases rather than COVID itself? And regarding that question also, there is the bit of verbal autopsy. What is its indication and exactly, and what are its indications and implications, especially when we try to link COVID and comorbidities? Is it effective? That's question one. Question two, we'd like to ask about healthcare providers. What are the ethics? What are the ethics around healthcare providers with comorbidities such as, healthcare providers with conditions such as hypertensive diseases, failing to go to work with the fear of, possibly coming into contact with the disease, given the risks that come with hypertensive diseases? The third question, just before we give you a chance to respond, before we proceed, regarding hypertensive patients. And the question is there any particular triage that happens when our positive patients arrive at the hospital? For example, do we have positive patients coming in, and then the facility, the staff at the facility, categorize them depending on their comorbid status? For example, hypertensive patients are, allocated a particular point just in case we may need targeted kind of approach. Is that happening? So maybe you could take the three and then answer before we move to the next session, if that's okay.
Thank you, Patrick, for those questions. I am not understanding the first question. So let me answer the two, and then you repeat the first question again, because I was a bit confused. So the second question was about healthcare workers who are aged a certain age and they have hypertension or they have comorbidities, and they may fear to go to work. So currently, we've just finished Human Resource for Health guideline document that will be shared, and I'll share through your leaders just for all of us to understand, because it gives a national guidance of the human resource required to manage COVID-19 based on number of cases, 5,000 cases, 10,000 cases, mainly in the isolation units. And basically it's a document that's supposed to guide the counties to see which human resource for health are required. And in that document, we've categorically stated that healthcare workers who have certain comorbidities should be protected from COVID-19, and therefore can be given duties in clinics that keep them away from the front line of COVID-19. So sort of to protect them. And in the guideline document, it's very, very clearly defined, and it actually lists hypertension is inside there, diabetes is inside there. I added HIV because I come from HIV world, although we don't have a lot of data, but it categorically lists which healthcare workers and how they are supposed to be protected. The strategy we've adapted in this country is very different from what they've done, I guess, in New York and Europe. Most Africa and most, we learned this many of our guidance for some of the recommendations and guidance we've provided has been learned from the East. So a lot of countries like China, North Korea, Singapore, Taiwan, who have a lot of experience. And basically in those settings, they've designated COVID facilities, COVID hospitals, where patients are nursed. So you have a specific area where patients would be nursed, but we are also working with like general hospitals to see how to minimize the risk. Because even in Kenyatta, we've had these exposures where a patient comes and then is diagnosed to have COVID when healthcare workers and other patients have been exposed. So to reduce that risk, we are working on what is called traffic control bundling to sort of have a triage port and a holding area where patients are kept if they have suggestive symptoms, if they fit any of the symptomatology in the case definition, they're evaluated before they're actually sent. So the ones who will test positive will be sent to the designated COVID facilities. The ones who test negative then would be sent to the general ward. But the holding area then poses a risk because patients can still get infected. So we are working to see how to space the patients and how to protect other patients who may be in the holding area and to prevent that risk of nosocomial transmission even in that area. So that may take care of that question of triaging and all that you asked thereafter. So again, when you ask your third question, it's about how to triage patients and to fast track patients maybe who might have hypertension and other comorbidities. So remember that your patients who have COVID will not come and tell you, Daktari, I have COVID. Your patient will come with certain symptoms. Then it's for us as healthcare workers to have a high index of suspicion to suspect the COVID and initiate the process of testing them. For patients who are already diagnosed, maybe through contact tracing, mass testing, or other screening procedures, they are sent specifically. They're even transported. There's a transport network that we've developed to take them to the COVID designated facilities. But for our walking patients, then the holding area and the triage at A&E and even our ambulatory clinics is what we are still working on to try and reduce the risk of patient getting COVID or even patient transmitting COVID within the healthcare setting. So that is still work in progress. But the most important thing is to always have that index of suspicion for our patients and to screen the patients and even to go ahead with the directive that was issued by the Ministry of Health. We haven't yet implemented it, which requires that all patients are screened for COVID-19. But remember, a negative test today does not mean a negative test forever. You can still get infected. So the question is, how do you periodically screen? What would be the interval for that periodic screen? I had a bit of your first question, and this was about the child who passed away, and the results came back a few days later. So just ask your question, then I can respond to it.
All right, thank you so much, Dr. So the first question was about the patient who had cancer as a comorbidity, whose COVID status was diagnosed post-mortem. So the question is, regarding such patients, and especially with the fact that we need data regarding COVID, isn't there any confusion about the data, especially regarding the cause of death of such patients when patients die of comorbidities? How do we treat the data? Do we count the deaths on COVID or on the comorbidity? And then about the same question is the fact that we have verbal autopsy taking place in parts of the country. So the question is, what are its indications and how does it, what are the implications regarding comorbidity and COVID-19?
So I'll try to answer, and I saw Dr. Walong somewhere. I'm hoping he's still on the call. He can maybe help us to answer that question. But regarding when a patient dies around this time and they have comorbidity and they have COVID, it's like an egg plus that chicken. When COVID comes, we know COVID is an acute cause of mortality. It's an acute cause of death. And therefore, in a patient with comorbidity, what we would not know is whether the COVID caused the death to come earlier before, so to attribute the death to COVID. So there are two aspects, whether you're saying the patient died of COVID or died with COVID, because the COVID could have been there, but did not really cause the death. So even for that particular child, it bothers me to date. I've not really had closure, because for most COVID cases in children, it's always good to identify an adult source, because children are staying at home, children are not moving a lot. So always we are working even within the hospital with our pediatric ID colleagues to try and see how, even for when you have cases of COVID in children, how to properly do contact tracing, like even we do in TB, because we know that in TB, most cases in children come from adults, and then even children are not very efficient transmitters. So we are trying to see whether it's the same in COVID, that all cases in children, we need to identify who's that caregiver so that we can even break that circle of transmission. Because even in the recent past, we've also had another case, but that one has had a good outcome. The repeat COVID test became negative. Child has a comorbidity, so he's going to get treatment for the current comorbidity that they have. And should they succumb to the comorbidity, then that's very clear, because you already had 2 negative COVID tests. Then we'll attribute that death possibly to the comorbidity rather than to COVID. So in a case where you diagnose the COVID at the point of death, it's really difficult unless you take additional history to find out what were the events leading to the death. Did the patient have features in keeping with pneumonia? Did they have features, suggestive of difficulty in breathing? And that's where maybe the verbal autopsy comes into play. So there has been this feeling that if this COVID-19 has been in the country for long and people are fearing to come into hospital, then the consequence of that is that we should be having unexplained and excess mortality out there in the community. And that's where the verbal autopsy comes into play, where when there's a death that has been reported in the community, then you try to investigate by asking a few questions to find out what were the circumstances behind the death. Was the patient sick? Was the patient known to have an underlying condition that could have contributed into death and all that, yeah? To try and find out whether really what was the cause of death for that patient. So in terms of the utility of the verbal autopsy, I think it's a good screening test to really help to quantify the circumstances that may contribute to increased deaths in the community, or deaths even within the community without, because patients are not coming to the healthcare. So I don't know in terms of utility of COVID-19, whether in the verbal autopsy, then we ask questions of symptomatology in keeping with the COVID-19, but in the absence of a confirmatory test, then you cannot attribute that mortality really to COVID-19. And I know the Office of the Government Pathologist and the lab team have been really working hard to sample all bodies that are maybe taken to morgues or brought in dead to facilities to try at least and have a test. But what is even surprising, for some of the patients who are brought in late into the hospital and brought in dead or died a few hours after being brought to hospital, we are having more negative tests, like they're not testing positive for COVID, and you'll find somebody maybe died of pulmonary thromboembolism, or somebody died of maybe DKA or something else that could have actually been prevented. So there may be a lot of excess mortality, but that's not to say that all mortality is actually attributable to COVID-19. If Dr. Along is still on the line, maybe can help us with the verbal autopsy part, maybe later as we go along. Thank you.
as Dr. prepares, I'd like to invite Derek. Derek Wachala, if you can hear me, you raised a question and we would like you to raise this question directly to Dr. If you can hear me, raise your hands and you'll be unmuted. Derek? In the meantime, Dr. There's a student who asked about, who didn't indicate their name, but she's asking, no, this is Cynthia. Cynthia from the University of Nairobi. She's asking, is there any data on the occurrence of severe disease on patients with multiple comorbidities, particularly hypertension and diabetes? And since Derek did not, I can't see, is Derek on? Derek, are you on? He isn't. So maybe we take the second question. And this is from Adit Vakel from the University of Nairobi, asking, it's too soon to make definitive statements, but have there been any potential relationships noted between COVID outcomes or severity and autoimmune comorbidities like SLE? And the third question from Micheni from the University of Nairobi is asked, the question is, there was a shift in specimen collection from nasopharyngeal to nasal. Please tell us more about this. Maybe we go with those as we move forward.
Okay, so the first question is about the multiple comorbidities and data, and I showed a bit of the New York data, which actually suggested that your patients who have multiple comorbidities, like in that series, about 72% of the patients had multiple comorbidities, which, and they were still, they were sick enough to require hospitalization. So in other settings, that has actually been shown. In our setting, as I said, our outbreak is still small, but we are really watching out for some of our patients to see if having multiple comorbidities translates to severe outcome and morbidity. And then, like I emphasized, remember again, when we have advanced age inside there and male gender, we'll not call those comorbidities. So even when we look at the national data, I'll add the national data as I share out these slides. I'll use the emergency situation report and just clip some of the graphs. So we have a lot of mortality. Like I said, most of our mortality currently comes from Mombasa. And from our colleagues on the ground, some of the patients who are dying, they'd have one comorbidity, but on top of that, they are of male gender and they are of advanced age. So we'll call it maybe one comorbidity, but have other adverse outcome criteria. So they are the advanced age and being of male gender. So definitely there is additiveness of comorbidities contributing to adverse outcome. Vakil's question on definitive statement of severity related to SLE. We haven't had a lot of data from even the Chinese data, from the US data of patients who have SLE having an adverse outcome. And we are watching the space. I know the Rheumatology Society issued a guidance, but what we have to remember, some of our SLE patients, when they have severe disease, they have to be on many of these immune modulating agents. Some of them are on hydroxychloroquine. Some of them are even on other monoclonal antibodies. And somehow maybe the monoclonal antibodies may actually be protective and protecting these patients. But again, remember your SLE is in a very confined group of patients. So again, largely in women who might be taking this immune modulating. So we need to watch out for that data. Currently it's not available, and they may get some protection because of the current therapy that they are taking that may act like maybe preventive therapy. But like I said, some of this therapy, even for COVID-19, is sort of preventive, but we don't know the effects in terms of whether they are protective. Michele's question on specimen collection is very, very interesting. So the challenge with COVID-19, it's a very new disease. The diagnostics are fairly new. And for any diagnostic test or recommendation for change of diagnostics needs to undergo validation. And validation is a process where you assess a test and see whether it's measuring what is intended to. measure. So when you're talking about collecting nasal specimen, when you talk about the nose is the front part here. And then we have the nasopharynx, which is the back part there. We know from biology that the virus is multiplying in the nasopharynx. And therefore, the yield of the virus from the nose, I don't know too much that it would provide a lot of yield. And currently, what WHO recommends is the nasopharynx specimen. I guess a nasal specimen would be easier, would be more acceptable, because when you listen to the lay people describing how the test is, it's like they put something long that goes to your throat. It's very uncomfortable and may actually prevent a lot of people from accessing. So a novel way of collecting the specimen through the nose would actually be a welcome relief. What I came across is that the oral specimens have a lower positivity rate and they are really to be discouraged. And for you to have a good sample collection, you must have a good nasopharyngeal swab together complemented with the oral specimen. So maybe it's just a matter of time until we validate the oral, the anterior, like the nasal swabs, to see whether they are really effective. Because the challenge with sample collection is, should you give your patient a test result and say they were negative, yet you sampled wrongly, then that negative test, if it's a false negative, has a lot of implications, because then your patient can go on to infect other people. So I think for now, the current consensus is really the nasopharyngeal swabs until we have more evidence to support a nasal swab.
All right. Thank you so much, Dr. for the response. So at this point, we would like to take, Dr. Malong is here. Dr. Malong is here and is willing to respond. Dr. Can you hear me? Hello, Dr. Malong.
I can hear you perfectly. I hope you can hear me too.
Sure, yes, very clearly. Thank you. Come on.
All right. So I'm glad my colleague, Dr. Maritim, has described the verbal autopsy and its application very well. And the challenge with the verbal autopsy right now is mainly validation. And we know that where the verbal autopsy is applied, it only gives broad diagnostic categories. For example, it can only tell us that this is a respiratory disease that is acute, likely to be viral, or like, in fact, it may not classify it as that. It may tell us that this is chronic, perhaps it's TB. Maybe it can be applied that way. So at the moment, being a new disease, as Dr. Maritim has said, the verbal autopsy may be quite limited in terms of application widely. The other autopsy approaches that we use is the minimally invasive autopsy, and that's what we've applied so far for COVID deaths. And of course, the complete diagnostic autopsy, but we are still concerned about safety. So we haven't applied that, and we may have, especially the case Dr. Maritim is talking about, the pediatric case, like these complete diagnostic autopsy will have worked very well for this. The next question you've asked is about prioritization of diagnosis when assigning cause of death. And this is a reminder that cause of death is, it's not an exact science. It's best opinion available at the particular time based on that, on the features that are described in the patient, from clinical to pathologic features. So there are two things we need to do to assign cause of death properly. And the first is to identify the disease process with the shortest duration of onset before death, right? For example, the shortest, antemortem interval. So for most COVID cases, the main disease process will be acute lung injury, or the one you use the term diffuse alveolar damage, or if you're in internal medicine, the term acute respiratory distress syndrome is mainly used. And then the next thing is to assign the causal pathway for that specific disease process that's been identified. So the causal pathway is to identify what other disease processes are there that are linked to what you've assigned as the immediate cause of death that you had documented in 1A. And that means you have to look for the next disease process, which in this case should be maybe interstitial pneumonia or COVID pneumonia. And again, the duration of onset in terms of the antemortem interval, right? Which is the next one in terms of, remember that the immediate cause of death had the shortest duration to death, then the next one and the next one. So that is how you identify causality. So you link those with the term due to. So we could say that there is acute respiratory distress syndrome due to pneumonia, and you can classify pneumonia based on various approaches. And of course, if you identify the etiologic agent such as the infectious disease, then we say the underlying becomes the COVID or the SARS-CoV-2 infection or COVID-19. So remember, the causal pathway has to be linked. So the other disease processes that are identified and do not fall within this causal pathway are the ones that you will describe as contributory disease processes, and then include diabetes mellitus, systemic arterial hypertension, cancers, and so on. And those ones we will classify them as category 2, and it's the one Dr. Maritim has described as comorbidities. So the comorbidities are important in the cause of death classification because they help define the vulnerable population groups and also inform the physicians and the other care teams that these are people who may need further assessment or additional care. Okay, so it mainly informs level of care, and that is how comorbid diseases should be seen. So there are other scenarios, and I think you've seen a lot of descriptions on published literature looking at where the immediate cause of death is a thromboembolic phenomenon, and COVID has tested positive. Now those ones that is where now, because it's not a typical feature of viral infections to cause vascular diseases, especially in this context. And because you do not know much about this virus, so in this case, we will still require that the COVID is listed as a part of the causal pathway. So the embolic disease, if identified, should be linked to the COVID, because at the moment we still do not know much about it until we properly define the pathology of COVID. Right, so back to you on that.
Dr. Walong, sorry. Any comment on the nasal swabs? There was a question on the nasal swabs. Do you have any experience with the nasal swab vis-a-vis nasopharyngeal?
No, I've mainly used nasopharyngeal swabs in our influenza surveillance studies, and we see that as the standard of care. Maybe the potential for nasal swabbing, maybe it's more just ease of use, but that one I've not used it much, so I don't even comment beyond that in terms of its utility. But maybe it's more of a stopgap measure, where what I've seen sometimes is that there may be a shortage of kits, and the next best option is to use what you have. And I've seen sometimes that where the kits are not available, then you have an inflexible specimen collection swab. And in that case, the only feasible approach is to do an arterial swab on the nose. As to whether it performs as well as in nasopharyngeal, we've seen published data, and it shows that there may be increased incidences of false negatives. Yeah. Right, back to you.
All right, thank you so much, Dr. and for sharing. That was insightful. So at this point, we would like to take some live questions. So we'll ask you to raise your hands. Like, for example, Derek Wanjala, kindly raise your hand so that you're unmuted, and you'll have a chance to speak to Dr. And once you're on, kindly just ask your questions. Derek, are you here?
Yeah, I'm here.
All right, wonderful. So just before then, Timothy Socrate. Timothy Socrate, kindly raise your hand too and you'll be unmuted after Derek. So Derek, welcome and raise your questions.
All right. Dr. Maritim, Dr. Walong, thank you very much for everything. So my first question is, I actually have 4 questions. My first question, more or less, might have been answered by Dr. Walong, he's the pathologist. My first question was, yes, I note that the current test kits that we're using are, the swabs are synthetic. So I was trying to find out if maybe there's a contraindication, or maybe if we'd get different results if we used cotton buds for sample collection, bearing in mind the country we're in, we don't have resources everywhere to meet all the needs that we need. So maybe if I am working at a peripheral facility and I'm not able to get the appropriate test kits, can I use my cotton swabs and get my cotton bud and get my samples and test them? Would I get my appropriate results? That was my first question, which he can answer later on. He's the pathologist. Then my second question was to Dr. Maritim. She had talked about negative pressure testing within testing centers. And we've all seen what is happening in our situation, in our country, especially in mass testing. We don't really have mass testing. So I was wondering, is this, by testing people, do we pose a risk to the public, to everyone else who comes to test? Maybe I come as a patient who's positive and everyone else on the queue who is behind me is negative. She mentioned that, yes, you will dispel all the microbes into the air. So don't you think maybe we're not really doing good to everyone else who comes and tests after me? And my third question was based on an article I read, an article from Italy, published on May 9th, that was stating that COVID-19 is not really the way we're all saying that it's all about pneumonia and all, but the article says that COVID-19 is a disseminated intravascular coagulation. It's actually saying, it's talking more about pulmonary thrombosis, and even the method of treatment, it's telling us to use anti-inflammatories, anticoagulants, antibacterials, and antivirals. So I was just curious to our lecturers, trying to find out what they think about that article, whether they've seen it and whether they think it's feasible or it's just someone trying to make a name, or I don't know. And then my last question was in light to multi-system inflammatory syndrome in children. It has been attributed to COVID-19. And we know as a country, yes, we have a very young population, we have many children. And my question is, we should be worried, yes, about all this, because if it happens out there doesn't mean it can't happen to us, but what are we doing about it? Have we taken measures to ensure that our children remain safe? Yeah, those are my 4 questions.
Hello, Timothy. Are you here, Timothy?
Yes. Hello.
All right, kindly. Hello.
Thank you. My question was going to Dr. Maritim. I wanted to inquire, she talked about the issue of the incubation period being 1 to 14 days, but she also say that sometimes it can go beyond up to 20 to 21 days. Now, I was wondering, like in most of the countries, like here in Africa, for example, Uganda, they are quarantining people for 14 days and they discharge them in case they have not developed symptoms. So now I'm looking at the instance, they have discharged the person after those 14 days. Then later in the community, he or she develops the symptoms. That will necessitate the national task force to start tracking for the contacts of that individual. So I'm asking, why is it that instead of quarantining the people for 14 days, why not it to be 21 days completely? Thank you.
Thank you for those several questions from Derek and a question from Timothy. So the first question for Derek was about the swabs. So the swabs are synthetic by deliberately, and this is because when you collect your sample, you're collecting the nasopharyngeal secretions, and you want the virus and the viral DNA. And what is the natural fibers like the cotton and other things that should be used, if they were used, they'd actually absorb the virus, but not be able to release the virus. So as soon as you collect your virus using the nasopharyngeal swab, which is made of Dacron, you cut the tip into a viral transport media, which is a special media to transport the virus and to inhibit any bacteria that may be there, so that by the time it reaches the lab, the virus is there and there's no other DNA that's available there. So that's the characteristic of both the nasopharyngeal and oropharyngeal. You collect the two swabs and put them in one viral transport media and you send to the lab. So the Dacron swab, what happens, it is able to obtain the swabs from the nasopharyngeal space. And as soon as you put it in the transport media, it releases the viral particles and the viral DNA and all that. Unlike the cotton, which would absorb and not release it. So that is really the standard of care. And for COVID-19, this is one disease you're not going to improvise. You're not going to improvise your swabs and start using your earbuds like the cotton swabs. You're not going to improvise your PPE and start using some other PPE that you just made Juakali, like without standards. So this is one disease that is a bit unforgiving. If you use the cotton bud swab, it may not give you a positive yield. It might even interfere. You might start even analyzing because cotton is from really like living thing. So it might even give you, interfere with the results you're likely to get when you send it to the lab. So what is recommended is Dacron swabs, and even the swabs, they are made of a specific structure. I think it's a wire or some plastic, some inanimate material that holds the Dacron at the tip, and that is by design to minimize any interference and to avoid any contamination of the DNA, so that when you analyze whatever is in the viral transport media is actually what you obtain from the nasopharynx, not a modification by virtue of the swab or the holder, like the rest of the structures related to the swab. So cotton is a no-no. In terms of your testing booths and changing kits, so your negative pressure can only occur in the setting of a building. So if you're doing anything invasive or nursing your patient or whatever, you can use natural ventilation to ensure safety, so that by ventilation, it's like the air is cycled, and there's even a prescribed manner in which how many cycles per minute that the air should be changed. So you can capitalize on infrastructural or environmental engineering controls to do that. And one of the ways of doing it is negative pressure. This is very different when you're going to take your samples in the outdoor. So when you're in outdoor, you capitalize on advantages that exist in the outdoor. This includes ultraviolet light. It includes the wind that is blowing that will disperse any viral particles, and therefore it's even safer. When you have an infectious person, you can keep them outside in the sun. Like when you have our TB patients, you can actually encourage them when you're doing your procedures, like if you want to obtain, what is it called? If you want to obtain some of the samples in children, hypertonic saline, for example, if you want to do hypertonic saline stimulation to get secretions in a child, you actually do it outside in the sun, and it's much safer. If you're doing it in a room that is closed, then you stand a higher risk because the droplets will be suspended in the air because the air cycle is not changing frequently. And that's where now negative pressure comes into play. So when you're talking about the diagnostic things in the community, like for mass testing, the most important thing is that the patients who will be queuing up are physically distanced, the people who are doing the testing change their gloves and sanitize between patients. And then there's a modification where you do an engineering control to protect even the healthcare workers. They'll definitely be having their PPE, but you put a separation so that the patients, even if they were to cough, there's a screen that would protect them from coming into close contact with those secretions. And then you capitalize on the ultraviolet rays to avoid, to provide additional measures of, or to sterilize that environment. So the risk for the rest of the population is significantly much lower because you're doing it in an outdoor setting compared to doing it in an indoor setting. When you're doing it in a room, that's where now the issue of negative pressure comes into play. So that's just my answer related to that. In terms of the DIC and the publication that was published by the Italian group on May 9th, when you look at it, it's sort of been a bit touched a bit by Dr. Walong when he was explaining the post-mortem findings and causality of death. So when you have these patients and they die and you do a post-mortem and find they had anticoagulation, it doesn't tell you that the anticoagulation was the main contributor. And really, their findings may not be entirely surprising because we know when patients are going into a state of severe inflammatory response syndrome, there's a trigger. And part of the cascade is really, you get what is a DIC or hypercoagulable state. But then it doesn't mean that all your patients, this will be the final pathway, because we know so many things, even when patients go into SARS, if a patient gets pancreatitis, they can go into SARS, they'll get a DIC. If you do a postmortem, you might find microthrombi everywhere. So it's a bit too early to say that's the final common pathway and the premorbid event for all your patients who have COVID-19, and therefore to recommend a certain treatment. Again, we know even if you're going to say antiviral treatment, most of the antivirals have not been shown to work. So which antiviral then will you choose to use? Anticoagulants, we mentioned that there's an indication for anticoagulants, especially if you do your D-dimers antemortem and they're high, you can suspect that your patient is actually undergoing DIC and therefore you can anticoagulate them. And actually newer guidelines even seem to support that for patients who have severe and critical illness, there's a role for preemptive anticoagulation. So for us who are in resource poor setting where we may not necessarily be able to do dimers invariably, when we are managing this patient, then we can give them prophylactic anticoagulation therapy. In terms of anti-inflammatory treatment, there's currently no known anti-inflammatory treatment that has been shown beyond doubt to be effective. Even things like tocilizumab, which is a monoclonal antibody that targets IL-6, has not really been shown to be effective and has not been widely recommended for use. So for now, we might know a bit of the pathway for DIC and in relation to COVID-19, but we haven't found that magical treatment that would work for all the patients. So it's still, the jury is still out there. Regarding the multisystem inflammatory disease or Kawasaki syndrome in children, we had a presentation yesterday. Currently in Kenya, we have 19 children who've been diagnosed with COVID-19 in different facilities. Some of these children are mildly symptomatic, some are asymptomatic. They were identified through clustering of diseases within families. Of this, we had lost already the child that we talked about. So of these children, we haven't had any of them who has developed any of these symptoms, but our rheumatology colleagues are actually on heightened alert. They're looking for whether there could be increased cases of Kawasaki. When you read about the New York findings, they actually have found increased incidence. So in those settings, they have very good surveillance system, and any increase in any disease then is quickly picked up, and then they evaluate the children. In our setting, sometimes our surveillance system is not very good, but our rheumatology colleagues would be really the ones to pick up Kawasaki disease, are on heightened alert, and they are looking out for some of these cases. And if should they find any, their plan is to look for COVID so that you can make the association between the two. But so far in the 19 children that are being followed up, none of them has presented with that Kawasaki illness or multisystem inflammatory disease. For Timothy's question, that's a good question about the incubation period. So the standard, what is standardly known as the incubation period for COVID-19 is about 14 days, but there's been data from the US to suggest that the incubation period may be much longer. in our setting, we actually stand a better chance to really study the incubation period. But the thing for incubation period is best studied, for example, when you have people you have quarantined and you're following them up and you want to see what proportion of them develop symptoms and around what day do they develop the symptoms. So you have people you are actually actively following up. In the US, it's a bit difficult because they're not even testing the people who are asymptomatic. They're not even testing the people who are mildly symptomatic. So some people can be having COVID in their houses and just waiting. But in our setting, in our countries, I think our country, Kenya and Uganda, maybe are doing similar things. So in Kenya, what happens for people who are exposed to a contact, they're actually taken up, they're institutionalized, and then they're followed up for development of symptoms. And beyond that, at least in Kenya, those people are being tested at around day 8 for the people who came from outside the country. For other people, they are tested around day 14. And therefore, you can even be able to pick up asymptomatic, or you can be able to pick up mildly symptomatic. So it's expected that for most people, you develop your disease and you develop the symptoms, or you are positive, your test will be positive about 2 days before the onset of symptoms. So for the people who are quarantined, some of them have not even been symptomatic despite the follow-up. Some of them even have tested negative. So again, so far in my country, we believe that the incubation period is more closer to the 14 days and the 21 days. So majority of the people, about 90% to close to 95%, would definitely develop their symptoms within the 14 days. And this 21 days was proposed by an American group because when they had the cruise ships that people who are in cruise ships that were repatriated, I think some of them developed symptoms even after the 14 days of observations when they're already released into the community, but they were a small proportion compared. So in a setting where you're not doing active surveillance, it makes a difference to follow them up to 21 days. So what we do, at least in the quarantine facilities, when patients are being discharged, they're still told to report any symptoms that develops after the discharge. So it's not a blanket discharge, it's a discharge with a guidance in terms of what to do should they develop symptoms, and they're already told what symptoms to develop. But so far, we haven't had patients developing symptoms even beyond the 14 days at the point of discharge from contact tracing at day 14. Thank you.
All right, Dr. Thank you so much for the responses. Thank you, Dr. Maritim and Dr. Walong. We really appreciate. And we have a number of questions which will go unanswered. But certainly that is why MSAKE is here, to have as many more webinars as possible. But again, thank you so much for the responses. And at this point, I'd like to invite Yas for the subsequent section. Thank you, Dr.
Thank you very much, Patrick. Thank you very much, Dr. Walong and Dr. Maritim. Sorry, guys. I know you have really good questions, but due to time constraints, we can't stay online forever. We have to limit ourselves. However, I will pass these questions later on to Dr. Maritim, and we'll post the answers on our social media websites. So first of all, I'd like to take this opportunity to thank Dr. Maritim. Thank you very much. I know today you had a very special and a very busy day, but it was her daughter's graduation, and virtual graduation, and she took some time, to still educate us, and she didn't leave us out. So thank you very much. We also appreciate the work that you're putting in the National Task Force, and from us as medical students and the country general and the whole country, asante sana. Thank you indeed. That was a very informative session, and we hope to learn a lot. And for those who couldn't attend, we will be sharing the recording on our YouTube channel. Also, thank you very much, Dr. Walong. Thank you very much for your contribution. We are very happy we feel good when a doctor or a lecturer attends our webinars. We feel like we are doing something important. So thank you very much. Also, indeed, your responses were very informative and educating. Also, we would like to take this opportunity to thank Daktari Online for helping us use their platform, their webinar platform, and supporting our webinar series throughout. So thank you guys very much. Please don't forget to visit their website and register with them. You'll have more opportunities to attend various sessions using their website. Also, thank you very much for all the attendees. We had attendees from very many countries, medical students as well. So thank you guys for attending and staying with us throughout these sessions. We hope that whatever you learned today, whatever you learn today, you'll be able to apply it within your communities. Remember, you're still part of the healthcare system, whether it's a fact, and therefore your role may not be in the front line, but your role may be in the communities. Go and educate your families, your neighbors, your friends, your relatives, your neighbors. If you see your neighbor gathering, go and stop it. Teach them how to wear masks appropriately. Tell them what is right, what is wrong. I mean, you're knowledgeable. You have the basic science in you. You understand the basic pathogenesis of the virus, the clinical presentations. Go ahead and educate. Fight the stigma that is going out there, the myths that is going out there. There are some people that say a vaccine will come out and there'll be a nanochip. I heard this today, and they will be tracking everyone. People will become infertile. I mean, there's so many myths going on around, but we are scientists, guys. We practice evidence-based medicine. Just sit down and educate them that is your role, and it's a very important role. Okay, so please don't forget that. And also, Dr. Maritim gave a very important tip, an exam tip. So if you're from your end, just know that a slight leakage, you're probably going to get something COVID-19 related in your exams, hopefully when school resumes. And yeah, so please consistently read. This is a good time to understand communicable diseases and how they emerge. And tomorrow we will be in the front line, and we will be at risk. So we need to learn how to protect ourselves, our patients, and the community at the end. So as you're sitting at home and we don't really have much to do, read something, read an article a day, read something about COVID-19, and just increase your knowledge on this. Just for the sake, we would like to also thank the webinar team. This webinar team came as a collection of all representatives from all medical schools, 9 medical schools in Kenya. We came as a team, and we realized that this is not possible. As medical students, we can't know COVID-19 because it's fever, cough, etc. We need to know more. We can't just tell people just wash your hands and it's fine. We need to understand the virus. We need to know more. And with universities closing down, educational opportunities have been taken away. So we don't really have much of a learning. That's why we came up with this webinar series, in order to ensure that all medical students are still part of the team and part of, they're not sidelined, and that we're constantly educating ourselves despite this times of lockdowns and quarantine. And also, the webinar team puts in a lot of effort. So thank you guys very much for all the effort that you have put in ensuring that this webinar was a success. And we'd like to let all the attendees know that this is our 7th episode in our webinar series, and every week we hope to cover different areas that the COVID-19 has affected. Remember, it's challenged the strongest of the healthcare system. So it's not a joke, it's something very serious. Yeah, so I have nothing much to say. So Eid Mubarak, by the way, to all the Muslims out there who have celebrated Eid today and tomorrow. I know it's a big sacrifice that you have to make, staying at home and not going out and having gatherings, but this sacrifice will be rewarded at the end, hopefully once we end community transmission. So guys, just before, there's this burning question I'd like to ask Dr. Maritim. As students, we know that this is going to affect our medical education, and medical school is not going to be the same anymore. The crowding around the patients' beds, and everything, and schools not opening, and we can't graduate without clinical practice or clinical experience, of course. So what would you suggest? So what is the future of medicine or medical education?
That's a tough question. The university is doing all it can to try and resume activities. You guys have your lectures, they're even talking of online exams. But at the center of all this is really patient management, patient education. So the other thing is, even patients are not there in the wards. The wards are fairly empty. So I can't really tell what will be the future of medicine. But what COVID has shown is we need to be alert on infection prevention and control going forward. When you read about the outbreak and how it started in China, the healthcare workers who actually handled the first patients were the ones who got infected. So for me, having you away gives me peace that you are not coming at risk. Because the moment we have you guys coming on the wards, the way you're so many, if you have a contact, then it means basically if any of you comes down, then we are closing the whole medical school. So I don't know going ahead, whether even like if you have simulated trainings, if you have online trainings, whether it can really replace, because medicine is about touching the patient, it's about listening to the patient, you know, those things of palpation, inspection, percussion, which you cannot even do online. Online is so passive, it's such passive learning. There's so much that you learn by listening to a patient, by hearing things firsthand. So especially for our medical school, which is very traditional, those things we cannot really replace unless we train you that way. And then you guys will be like online doctors. You'll not be seeing real patients. You'll be seeing patients. You'll be seeing patients online. A patient calls you and they present their history. Then I don't know, maybe you'll have gadgets to auscultate their chest virtually. I don't even know how that can be. So for us in the clinical area, we've had these meetings with the university leadership, and we feel that clinical medicine has to be at the bedside. Really, there's no substitute. So we don't know. There's even a plan by like to try and open up the country fairly soon. I don't know when. So we don't even know what that will mean, because you see, like all the interventions we put in place have delayed the outbreak, but we've become restless because we knew like we'd have 1,000 cases by a certain time, 5,000 cases by a certain time. But our cases have been too slow to come and people have become restless. People don't want to wear their masks. People are moving everywhere. Traffic jam is back in Nairobi. But the moment we open up, we can surely have an increase in the number of cases. So should we open up, then we definitely know that even universities will have to be opened up. They'll be opened up to the rest, like they'll be opening up really to the country. But for us in medical school, going by the numbers that we know of students, clustering around patients, it means then we all become a risk. The students become a risk to the patients become a risk to the students, the visitors coming to Kenyatta become a risk to the patients, and therefore it will be very, very difficult to prevent an outbreak. If we look at personal protective equipment, what would it be required? You'd be required to have N95 masks. You'll be required to have your face shield. You'll be required maybe even to come to hospital in scrubs. So you see all those infrastructural things that we need to put in place in the university. This is actually the time to think about what would it cost? Because even N95 masks, you know, our ward rounds are very long. What will we do about the ward rounds? Should we be having a quick round? Should we maybe bring the patient to a place instead of going to where the patients are? You know, those are things that we need to really, really consider. And medical school may be one of the colleges or the schools that opens the last. Because you see, if you're teaching Bachelor of Arts or Law, you can teach online. But for medicine, you have to touch the patient. Even clinical exams, we give you a clinical exam where you clerk a patient for an hour. Now, this one, I don't know how we'll give you it's like writing an essay on a patient theoretically without touching the patient. So it's very difficult. Some people have given examples of Imperial College and some universities in the US that graduated their students. And so it's a very difficult time. And particularly for some of you who are very young in your medical training, if you're in 4th year, if you're in 3rd year, if you're in 5th year and 6th year, at least they have some clinical experience. But for you guys, you haven't touched enough patients to say like now you can move on to online. So it's a very difficult question that I might not have all the answers fully. And I think there's a group that's trying to look at what would it take to have medical school. We have the postgraduate programs, but again, we encourage the postgraduates to come few at a time so that the exposure is minimal. So again, we've had some exposures where some of them were looking after a patient and then the patient tested positive. So it becomes a challenge because now you have to send them to quarantine for 14 days, test them at some point. So it becomes very challenging for you guys because especially in the undergraduate, you are very, very many. So it will be a bit difficult. Sorry, I may not have given you the answer you're looking for, but that's the reality.
Yeah, it's the reality. I guess there's no solution but just to be patient and see how this thing unfolds. Indeed. Anyways, thank you very much. Dr. I see your son has spent some time with you, so we wouldn't want to take much of your time. Thank you all for attending the session. Please feel free to contact us if you have any questions, any inquiry about our series. Asante sana, good night, good evening, everyone.
Thank you.
Thank you. Thank you for having me.
It's our pleasure. Thank you. Okay. Bye, guys.
All right, bye. Bye-bye.